tendency that you'll realize.
Sure. So you would think do a stress, and if you
I
can
am
get
doing
away,
stress views in all my cases.
sure. If you in this case, if you do a stress, looks okay, you would carry on and do a.
Oh, sure.
Sure. Okay. Fair enough. I think that, I mean, that's what we unfortunately had. We had some amount of this thing. ACL was totally intact. Nothing else there. We had already made a decision with her on this thing, but it's just sort of something that caught me. Maybe we could have just done a uni in this, and we might just have got away. So I thought maybe I did an overkill by doing doing a total in this.
So
case.
if you can just go back, just
Yes.
a small point I want to make. Just go back to the previous slide.
Okay. Oh, so okay. So the FFD actually just by the time we got the GA, it was absolutely straight. So that's the reason. That's the problem. So it was wear extending. That's the reason why we were actually thinking of maybe not doing. It did, yeah. I saw the osteophytes in there, but with again, I mean, as you're saying, so maybe I think loosening the indication a little bit kind of a stuff.
Can you just go to the previous slide, Gurinder?
Can you go back, please? I don't know the going back button on this.
There's a small point I want to make. That's
This is the only way
there's
forward is this. Going back, boss? Is there a going back button which I can't see? Is that
so yeah, that one.
okay?
No, the one after this.
The clinical one or the
The intraoperative.
intra?
So like you said, the flexion deformity itself is not a contraindication, and you see that the anvil osteophyte right sitting
Yes.
there even in this,
Yes.
and that's something which will prevent a complete extension. And another reason that you must make it a point to remove it, and you can just overlook it and then it can create problems. So that's something on lateral X-ray also you'll see. So don't worry about a flexion deformity if you see that anvil osteophyte.
Fair enough. Okay. So can I just go back? So is gender, Yash, anything that you think about when you're deciding for a uni or a total?
Yeah, sometimes if it is a very small, frail Indian woman who's very small, female, I might not want to do, where I think I might have to use a very small component, and the risk of fracture in those is supposed to be higher. And if somebody's got osteoporosis also with that, so I might refrain. That's my only situation where I would consider gender a problem. Otherwise, no issue.
So as a rule of thumb, you don't see
No,
that
as a rule of
men
thumb,
do
no.
better or women do better. Nothing at all. Any change exactly as
So
Yash?
there are two different questions. So one is about the females. So of course, the AA, tibia and extra small femur are not recommended by the company now. So if the sizes are there, they have been shown to have more failure rate. So if I'm doing Oxford, I'll not do AA if it is there, or somehow try to get an A, or just not do it. So that is one point, like Dr. Gulati said, the size of the patient, short female, osteoporotic bone, very heavy female. But then generally, the men do much better in my series than women as far as the outcome is concerned. The range of motion, satisfaction, walking ability, everything is better in our series in men.
So one thing that always comes out is age is never a factor when you're deciding. It's not a time pass operation. I think time and again people keep telling me, nahi, thodi der ke baad dusra karwa lenge. It's never like that. It's got to be that one operation for a lifetime. Do not sell it as the part-time kind of stuff. And there is registry data. There is zero doubt. Nobody would doubt that the revision rate in a uni is more than a total, but it's not a time pass operation. And one thing that always stands out, the function is very, very high.
But
In a, yes.
that is more an academic take than a practical take. If you get a 45-year-old patient with a grade 4 arthritis, relentless pain, I would sell him the partial knee saying that it is a bridging operation. That, because see, in his lifetime, he will need 2 surgeries. That's what I go back to the patient. Rather than having a total knee and a revision knee,
Sure.
let us have a partial knee and go into the total knee.
That's right.
That journey is much more acceptable both for the patient also.
Sure.
Again, partially, let me tell you, the patient is not bothered about the literature. The patient is not bothered about the registry. He is bothered about how many years he will have a pain-free movement, and he puts all his trust in you. That is how you got to, that is how I would say that.
Yeah, that's absolutely.
If it's a 70-year-old patient,
Yeah.
I'll say, boss, this is the one operation. But a 40-year-old patient, I will never say, this is the only operation.
Agreed. So the one thing that will always come out is he'll get 2 or 3 opinions in a city like Delhi where everybody will get 2 or 3 opinions. And you need to sort of sell it right. you know, again, I totally, with the 42-year-old, I won't really think about doing anything.
Typically, if you have a patient who's actually not pointing to the medial compartment and is putting his hand on the entire knee, this is where it hurts. Would you still consider, even if the X-ray suggests it's only medial compartment?
So that's a very interesting question. Not as per Oxford, but then I would if the patient is 45 or 75.
And second thing is pointing only to the medial compartment of the pain is very arbitrary and very, very subjective.
Uncommon.
A
Actually,
lot of
it's
people
not that
are
common.
confused, myself confused, bloody where the pain is coming from. So I can't put my horses on that.
I think as Rajesh mentioned that because of the malalignment, the medial faceta patella is overloaded and that causes anterior pain sometimes. So we have to be careful. It may not be pure medial pain many times.
Rajesh, very quickly, 78-year-old guy, his BMD, which he had got himself, I did not do it, shows minus 2.3. And his range of movement is this, deformity is this. Would you consider that as a contraindication for doing a unicompartmental?
Not in a male patient because bones are larger. I'll go more laterally, try to put a larger component and treat osteoporosis. The osteoporosis is not going to go away in 6 months or 1 year in this patient, but in a female, yes, I would definitely be worried.
I would, if you look at this lateral compartment in this patient, I'm not happy with the lateral compartment. I would definitely want to do stress X-rays and establish that lateral compartment is actually okay. If it is okay, I'll be happy to offer. But at least in this case, I would definitely do stress X-ray.
Osteoporosis is the one. So the one very, very last sort of operative scenario. So this is an ACL issue. So you went ahead and you were trying to do a uni, and you'd already put in the component. And just when you were trying to put in the last component, you realized that the ACL had lifted off. What would you do in that scenario?
We have published. We would repair it and go and keep it. Keep the uni and we would repair the ACL. We have published that.
Okay, and if you just done your cut, tibial cut, and you realize my ACL is now getting this.
So if it is still a patient where otherwise I would be happier doing a uni than a total the extreme of ages, I would still go ahead and do the...
So you won't err towards the total in that kind of a scenario?
Yeah, I would be very different if, fortunately it has never happened to me, but if it happens, my ACL is not there, and I made the cuts, because in every patient of uni, I have TKA stuff there, every patient. And I would just go ahead and do TKA at that stage.
All right. So this is one case in which the ACL was this. A very, very quick one. You get a patient who's, you put in your poly and you're trying to move the knee and you see the poly come out immediately. Well, when I say come out...
Well, then in that case, I think I might have ruptured the MCL. If it is coming out peroperatively, it will definitely come out again. I will just change it to TK. There's no question. Thicker poly and all, you can try 1 or 2 thicker. But, if that's happening, my tentacles will be very up,
Is there a limit to this kind of a tilting which you will accept? And you say...
You mean tilting or going out?
Now,
Sorry.
Now change the question. The second one is, if it just angulates out when it comes to extension, it will always sit parallel when it comes to flexion.
If it is tilting, maybe it is too tight. Why? Otherwise, it should not tilt, or if it is too loose. See, the only problem with mobile uni is that if you can prevent dislocation, it's a fantastic operation. Fantastic, and there are no comparisons. But if there is any doubt about dislocation, I don't want an egg in my face later on. As simple as that.
Is there a get out of jail card out here which you can do to make a difference at all?
Sorry, what did
Is there a way to get out of the situation?
Yeah, I would, if I did 2 years back, I was convinced that this patient needs a UKR. I'll definitely put a trial, poly same size, and then next size, and see how the knee is doing. I would look for any cause for impingement and cause for dislocation. If the rotation is wrong, if there is impingement, if there is such cause which cannot be corrected and the dislocation is going to be recurrent, I'll revise it. But if it feels stable, I'll just keep it with the next size.
Perfect.
And I've done that many times, and the patients have been doing well.
Perfect. Thank you so much, gentlemen, for this.
Thank
Can
you
I request Suhas to take on the next talk? It's on... it's what robotics in UKR. So still continuing on the same topic. You're okay with that, Michael?
Good morning, everyone. I think that was an excellent session where you had 3 very experienced surgeons who discussed how you could indicate a uni and how to deal with complications. So I'm being given the task of discussing about robotic uni and does it actually make a difference. And in the second part of the lecture, we will directly go live to surgery, and I've been given the task of showing you the preoperative plan, and then we will go live to Hyderabad, where we'll actually discuss and then go through the live surgery done at Sunshine Hospital by Dr. Adarsh Anapareddy. So we've just discussed why uni is such a good surgery. Obviously, you're retaining the anatomy in your patient. It is almost like a resurfacing procedure, so the natural kinematics of the knee are restored. So this gives you good rehabilitation, excellent range of motion, and good patient-reported outcomes. We ourselves did a study where we looked at 2,500 knees, intraoperative as well as radiographs, to see how many of these patients who were undergoing a total knee actually qualified and could be indicated for an AMOA, and a uni could be done in these patients. And you could see that almost 47% of our patients had criteria which met the Oxford criteria, as well as had clinical evidence of ACL which was intact. The lateral compartment was pristine and there was medial wear. So there is high incidence of AMO in our patients, and then there is scope for unicondylar in our patients. But then what is the challenge? The challenge is technically it's a very demanding procedure. So you could just see that 3 very experienced surgeons who do big bulk of their practice as unicondylar might have less complications as compared to somebody who's just starting off. If you have an error, if you have malalignment, the chances of failure are high. So hence for you to have actually a good outcome, it is important that you have good sizing, good soft tissue balance, and the overall alignment has to be maintained. This is a position statement by the Australian Orthopedic Association, where they were referring to the role of robotics in hip and knee surgery. And clearly you can see here the recommendation for hip and knee is still not there. But for a unicompartmental, there is evidence to suggest that robotics does make a difference. So what is the additional benefit of using technology like robotics? Here you can see the one that we are showing you here is an image-based robotic assisted arm surgery, where there are 3 big advantages that you can have. You can plan your surgery well, you can balance your knee well, and then you have haptic guidance to actually do your bone preparation. In terms of planning, you can get accurate sizing as well as accurate alignment. You can decide what is the size of your femur, what is the size of your tibia, where to position it, and change it in all the 6 axes. And then once you capture your gaps, you have the ability to balance the knee out. Instead of going for a manual feel, you actually have a graph, you have the numbers on your screen, where you can decide what is the overall laxity or tightness that you're aiming. The recommendation is usually a millimeter of laxity from flexion to extension. And you can clearly see here, you can also align the implants well so that you have good tracking and you don't edge load the implant. And then in the end, you have the haptic guidance module, where you use either the saw or a burr in order to achieve the surgery or the plan that you actually decided. And this is done with millimeter accuracy as well as soft tissue protection. So on the left, you have the post-operative X-ray, the pre-operative, and on the right, you have the post-operative X-ray. So is there evidence to show that robotics is actually making a difference? So this is a very recent publication where robotic versus manual unis were compared. This was a systemic review as well as a meta-analysis by Nick Clement, who I think is regarded and well respected as a very neutral opinion maker in terms of whether robotics is helping the patients or not. Here, the study is more important because previous meta-analysis were both multiple robots and multiple implants. This is the first meta-analysis where they used a single robot, where in this case was a Mako robot, and it was a single implant, and they compared to manuals. And what all did they compare? They looked for learning curve, they looked for precision in implant positioning, they looked for complications, survivorship, patient-reported outcomes, and something which is a little less relevant to us is the cost effectiveness. So clearly you can see here in terms of learning curve, robotic UKR has a learning curve, but it is only time dependent. The learning curve is not there for precision. I'm the prime example of this. I've never done a manual uni. Right after fellowship, when I came here and when we started robotics, I was very comfortable doing a robotic uni because I knew the time factor is only a matter of learning curve, but the precision is given by the robotic. So hence, I will be able to achieve the right alignment, balance, as well as preserve the joint line restoration very well. But on the other side, where you saw, for example, if you see the data from the mobile bearing unis, there is a steep learning curve. Initial 40-50 cases, there is a chance for morbidity as well as high revision rate. And the current recommendation is at least 25% of your practice has to be uni, or on an average, you should be doing at least 40 cases of unicondylar to make sure that you avoid any complications. So in terms of learning curve, robotics definitely has a distinct advantage over manual unis. Second thing is about precision of the implants. So out of the 5 papers, 4 papers clearly showed that robotic unis are more accurate in terms of positioning and they were less outliers. And this should translate into good function as well as longevity of the implants. The third one, in terms of complications, you could see there were slightly higher complications in manual unis versus robotic unis. And in terms of revision rate, over a period of medium term, you could see the revision rate in robotic uni was 1.7% versus 3.3% in manual unis. And this is very similar to the Australian registry or the New Zealand registry, where you see on an average in the early post-operative period, there is 4% revision rate. In terms of prompts, I think this is more surprising. Though we decided and we thought that there would be much difference in terms of patient-reported outcomes, this study clearly shows there was no difference in either KSS as well as WOMAC score. Partly the reason could be that both these scores have a very high ceiling effect, but in terms of the results, you could see that there was no difference in prompts between the two. So the take-home message is very clear. For a AMOA, UKR is definitely the surgery of choice. It retains the natural knee kinematics, but technically it is a much demanding procedure. Either you move towards manual surgery where you do bulk of your practice, overcome the steep learning curve and avoid complications. But the other option is to go for robotics where you have no learning curve. You can ensure accurate position right from the first surgery. You'll have less complications and better survivorship. But in terms of prompts, I think you need better scores in order to elicit a difference between a robotic or a manual uni. So that's the end of my talk. Should I go ahead and then discuss the case? Okay. So we have Dr. Adarsh in Hyderabad who will perform the surgery. In the interest of time, I would first go through the case, after which we will go live to the live surgery. And yes, if I can have Dr. Vikram Maskar to come up on stage. Great. So in terms of case profile, this is a 74-year-old male who had bilateral knee pain for the past 1 year.
You already zoomed in.
The activities of daily living were affected. Just 3 days ago, the left side was done, where a total knee was done. That was also done using the robot. And today we are looking at the right side, where you can see there is less involvement as compared to the left. You can see that the medial compartment wear is there. We don't have the stress views here, but you can see that probably the ACL is intact. You don't see much rollback. You can see that the posterior aspect of the tibia in the sagittal view, that you have some amount of bonelets, so there is no posterior wear in this patient. So in terms of preoperative planning, it is important for us to understand. So out of the 3 aspects of robotic uni, I'm discussing the first part, which is the preoperative planning. Here you can see you do a CT scan in this particular system because it is image-based, after which a 3D reconstruction of the knee is done. Here you can see this is a size 5. You can very accurately see the mediolateral fit as well as the AP fit of the implant. And in the coronal view, we can also look at the ACL footprint. Sometimes when you do manual UKRs, you're worried about undermining the footprint of the ACL. Here you can actually position it pretty well and make sure that your implant is on the outer half of the slope so that the ACL footprint is not affected during surgery. And then on the sagittal view, you start looking at the slope of the implant. It is very common for Indian knees to have high slope. So here we've already put the slope at 7 degrees. But if you want to see the natural slope in this patient, probably it's around 9 to 11 degrees. But in this case, in our center, we've decided to go up till 9 degrees of slope. We haven't gone beyond that. So here, in this particular case, we are only doing 7 degrees of slope. So it's a size 5, ML fit is good, AP fit is good. We are not compromising the ACL footprint, and we have a tibial slope of 7 degrees. And it also is possible to position the proudness of the implant. The general recommendation is to keep the plant 3 millimeters proud, so that you don't take more than 5 millimeters of bone, beyond which you start weakening the medial aspect of the tibia. Similarly, on the femur, you have a size 5 again. We look at the medial lateral fit. And most important view here is the sagittal view, where you want the concentricity of the implant being maintained right from posterior to the anterior aspect. Here, we usually leave the implant 1 millimeter proud, and then we have the ability to adjust the implant to keep it closer to the notch. Usually in uni, you want no edge loading. You want the tracking to be very good. So usually we move the tibia more medial and move the femur more lateral so that they align well. And this can actually be confirmed even before you start surgery, where you can see on either side of the femoral implant, you can see some amount of green, which is actually the tibia. So if no adjustments are made in this particular case, and if the knee balances on its own, you know that you have very good tracking in these implants. If you have to make some adjustments in terms of balancing the knee, you come back to the same picture to make sure that you're still tracking well. So this is in brief the preoperative plan, where we know the sizes, we know that the implants are tracking well. So we go live to Dr. Adarsh Anapareddy. Dr. Adarsh, can you hear us?
You can hear me?
Yes, we can.
Perfect. Thanks, Dr. Sahas. Great introduction. So as you can see, I'm wearing my lucky Spider-Man cap. Okay, so, right. So if you see, I'd like to first start off by showing you the 3 criteria that we always check for. First is a medial compartment, bone-on-bone arthritis. Can you see this? Can you get in a zoomed-in view, please? Camera 1, zoom in to the joint. So I've already exposed and put in my pins. So camera 1, please. Move this light out of the way. Not you, not you. That's not sterile. Is it? Okay. Yeah. Are you able to see that now? This area is the bone-on-bone arthritis. Can you see, Dr. Sahas? Hello? Are we online still?
Yes, Dr. Adarsh, we can see it.
Yeah. You can, perfect.
Yes.
Then the lateral compartment. I hope you can see this too. I'm going to just move my hand a bit. It's pristine. The cartilage is completely intact. And the ACL is nice and bulky. We have a very good ACL over here.
If we can get a top-down view so that we can
Show
see
me
the
camera
ACL.
2. Camera 2. Yeah. Can you see this ACL here?
The
Yeah,
view
can we
could
get a
be
better view of the camera from
yeah.
front? We can't really see the ACL.
Right. Take this view and zoom it in for me. Camera 1.
If it can go right on top of the knee, we'll be able to get a better angle.
Yeah, unfortunately, they don't have that kind of camera.
I think let's assume that the ACL is good, and then let's move on because we just have 30 minutes.
Yeah. So only issue is there is some patellofemoral arthritis, but as the Oxford group says, we shouldn't have to worry too much as long as it's not spreading to the lateral side. So this is a plus-minus case, but because he's 74 and he was showing only medial pinpoint tenderness, I'm going to go ahead with the uni. Right, so my arrays are in place, and I've also put my checkpoints in place. Now let's give a view of the
Others, just one question. Can you hear me? Vikram here from...
Yes, yes, Dr. Vikram.
Yeah. From a patient selection point of view, having done a TKR on the other side, do you feel that the patient is likely to compare both sides? And would that influence
He
your
may,
decision?
and he will actually find this side better, I feel.
So the other side being done by you, do you think you're buying yourself trouble?
Not necessarily, because the other side he was showing the whole joint pain. That's what you guys were discussing earlier.
I think that's it's become standard practice in our setup where we let the pathology demand what surgery we do.
Exactly, exactly. We have explained the reasons why we're doing a partial on this side and everything. They're quite receptive to it.
We have done around 30 to 40 TKR one side, partially on the other side. And 90% of them say that the PKR feels natural. That is what we use it. That's what it is.
Yeah.
And then
right.
we
So
just
the first
just,
step,
yeah.
I'd like a picture-in-picture. Show me camera 1 and camera 3, please, quickly. I need you guys to move faster.
So we're going into the registration part of the procedure.
Yes. Come on, guys. Right, and picture-in-picture, please. Camera 1. Right, can you see this, guys? Is it too small? Increase the size of the PIP.
Yeah, any
right,
robotic...
I'm going to now rotate. Start capturing, please, Darshan. I'm going to start rotating so that the robo knows where my center of the hip is. Okay, that's accepted. Block it. I'm using a foot holder here, which is one of my favorite things, to make sure that everything is stable. Now it's asking you where the medial malleus capture and the lateral malleolus capture. This gives me the mechanical axis. Capture, verify the checkpoint on the femur. And I have a checkpoint on the tibia here. Capture and verify. Right. So the major points have been taken. I have a foot pedal here. This is called a brew probe, which is very sharp. And I need to show 40 points to the robo, so it knows where the bone is in real time, so it matches with the CT scan that is taken.
So this is where image-based and image-less robots differ greatly. In an image-based system, you're trying to match the anatomy of the patient to the CT scan. Hence, the accuracy of the points is much higher. Whereas an image-less system usually uses software as well as the points derived by the surgeon during surgery in order to bone morph the whole implant and the anatomy. In that case, you have chances of having less accuracy as compared to an image-based system.
So Suhas, are these points arbitrary points, or these are patient-specific?
The pattern is the same.
But they're arbitrary. They're arbitrary. So I can take them anywhere, but these 6 points I just took are actual anatomy. So the verification points, did you see those 6 bubbles?
Yes.
Big one?
So if the question
those were on the actual anatomy, which I'll show you on the tibia as well. These 40 small points are arbitrary. You can go anywhere as long as you're in the ballpark.
Yeah. You're not actually hitting the point. You have to be in that specific area. Usually they are right angles to one another so that you get a good registration.
So you get all the different planes. So the more spread out you are, the more accurate you'll get. Darshan, I'd like you to just take the cursor and show the accuracy so that they know how much accurate we need to be. See that it says overall accuracy is 0.4. As long as it's less than 0.5, it allows you. Now these 40 points have been conglomerated into 6 big bubbles. Now this is real time. Now you can see my probe moving along with the screen probe. These have to be exactly on the right spot. Otherwise, it won't let us go forward.
Yeah, it's like a secondary verification.
Yeah. Because after this step, I'm going to be trusting the robo blindly. So I need to know that it's exactly matching the plan. Right. So the first difference here is, usually in any conventional case, we take out our osteophytes as soon as we open the joint. But here we have to we have to refrain from doing that until we have taken out our osteophytes. Chuck, what's the checkpoint? I mean, until we have done a registration, because the CT scan was done with the osteophytes intact. Don't block the camera. Retract here, please. Niche. Don't block the video camera, I mean.
Just a time check, Dr. Adarsh. We are
Yeah, give me a... Yep, comments. Right, give me a curved osteo. Just knocking off the medial osteophyte, we call it the joint rat.
So it's important that you remove the osteophytes before you stress and capture gaps. So that is the step that's currently on.
So after registration and before gap ligament balancing. Right, there you go. So our osteophytes are out. I'm ready to now balance out the joint and see what
are my... Can we have the front camera, please? I think we're seeing the whole knee from the side.
Please give me camera 1 until I mention otherwise. Yeah. Camera 1? Yes, you're saying yes, but you're not giving it to me. This is camera 2, right?
Good morning,
This is
Adarsh.
camera 1? Okay. Yeah, this is straight on you. Is it more visible?
Yes.
Okay, lovely. Right, so now see what I'm doing. Now get a zoom out view, please. Maybe a camera 2 with a zoom out view. So they see what I'm doing. Wide shot. There you go. Okay, there's a camera right in front of me there.
Right questions on unicompartmental knee replacement. We can actually have questions both on the QVIS report. We have enough experts in the sitting amongst us who can talk to us about the MAKO. We can discuss indications, contraindications, anything else that you have in mind. Tell me about. Tell me about implant prominence. You said we want to leave the implant prominent by about 3 millimeters. What, I mean, is that above the native tibial level or the level which had receded to?
So, so the concept is different from a total knee to a partial knee. Here, we are just resurfacing the joint, right? So on the femoral side, we are trying to recreate a millimeter of cartilage wear on the femoral side. But on the tibial side, we have to be cognizant of how much amount of bone we are removing. It has to be equal to the combined thickness of the implant. So the way it is calculated is if you're 3 millimeters proud, you tend to remove 5 millimeters of the implant, which is about 8 millimeters. So that is the hard stop that is set by the company or the implant where if you go deeper, then you're going beyond 5 millimeters and you will start weakening the bone. So it is a hard stop based on the combined thickness of the implants.
Perfect. Okay. Any other questions? Can I just ask, how many of you, a fair amount of people out here, how many of you are routinely doing unicompartmental knee replacement, say about 3 a month?
Recording stopped.
That's a very few people. How many of you actually aspire and believe that unicompartmental is an option? Or how many, sorry, let me take it the other way. How many of you don't think that unicompartmental is actually an option you should give to any patient? Anybody who's got zero faith in unicompartmental? No, good. People are getting convinced. Okay. So what stops a lot of people? There's so few people actually doing it. What stops a lot of you from doing any unis at all? Anything? Is it lack of training, a lack of awareness? Why aren't people using more unis at all? Anybody? Any answers? Rajesh, why do you think it's not got that common? It's actually a fairly easy sorry, I'm not saying easy. Sorry, what I meant was easily available surgery and training options and all are there.
Yes, so now the training options are there, but I'll tell you what the problem is. The problem is that the patients were always there who needed UKR, but people were scared of fixed bearing. There were a lot of contraindications, even patellofemoral joint arthritis, the anterior knee pain, and that was because you were worried about malpositioning the components that we knew would lead to edge loading and cause a failure. Still, Dr. Maria, Dr. Rajgopal, they were doing fixed bearing for quite some time. Then came along Oxford. So here there was no problem about malposition. So you could, it was a spherical femoral component, you could put it in any position, varus, valgus, internal rotation, external rotation, nothing matters. So there was a surge. But then the problem of the dislocation came. So people started getting worried about the dislocation in the mobile bearing. And then came the robot. And when the robot came, robot said, fine, we'll give you something which has no problem of the bearing dislocation. We can put the component perfectly. This will work very nice. And people knew that they are opening everyday knees which have got normal lateral compartment, normal meniscus, normal ACL. And this is the robot which has made UKR popular again. People who are still not not adopting are those who are not adopted robot. But I can assure you the day they buy a robot, they'll all start doing unis because that everybody knows is the best indication for robotics.
Sure. So Has, tell me, I mean, a fixed bearing uni and a robot is a marriage made in heaven. But in my opinion, a mobile bearing and a robot is, I don't think that important. Am I right, or is that a wrong statement to make?
Well, if you're able to balance the gaps well, a fixed bearing or a mobile bearing should do equally well in terms of how the gaps are there. But MAKO uses Restoris implant, which does not have a mechanical instrumentation available. On the other side, you have the mobile bearing implant Oxford, which does not have the robotic option available. So I feel if you're able to balance the gaps, it doesn't matter what type of insert you're using.
Because you could actually get away with a mobile bearing much more because there's no edge loading or something is what Dr. Malhotra was saying. It's not an issue at all. So maybe in my opinion, I thought maybe you can just get away with that.
So I think the biggest deterrent for a younger surgeon, to hop onto a wagon of doing a unicondylar is trying to do it manually, going through that learning curve, knowing that he might falter and end up in some sort of complication in his initial cases. I think that is the big deterrent which keeps surgeons away. And that's how I told you how I could easily do a robotic uni as compared to a manual.
So I'll say what Soha said, which is a fact. There's a zero learning curve for a robotic UKR for putting the components properly. So that is a big factor why you said the uni is coming back again.
Fair enough. Okay. Any questions on the topics that we just discussed? Any thoughts, any suggestions? How much of in your opinion, how many patients out of 100 knee replacement guys do you think are candidates for a robotic, and how many, give me a percentage in your opinion?
Well, literature says almost 10%, 10 to 15%. And if we follow the indications properly, then I agree with that almost 15% of the patients can undergo UKR.
No, talking about a robotic total knee.
Robotic total knee.
Is there anybody whom you say, look, koi fayda nahi hai? When would you push hard and say, seriously, why do you want a robotic? Or not a candidate for robotic? Is there a category like this at all?
So the indication of robotic, I think, is more relevant in complex cases, in obese patients. So these are the cases where the robotics have got more value.
More value, sure.
Otherwise, in, I think, standard deformities, even the standard conventional techniques are quite good enough. And till now, the PROMs, the patient-related outcomes haven't been very different in robotic as well as conventional. But of course, in obese patients, because you don't have to take out the tibia for the, you don't have to subluxate the tibia for the tibial cut. You take all the cuts before you subluxate the tibia, so that makes things very easy. Sure. And in complex deformities, you can plan it much better.
Sure.
So naturally, the soft tissue releases, they have definitely gone down in robotic surgeries.
Sure, fair enough. Yeah. So Mahesh, they keep talking about the robotic is much more less painful, less invasive. I mean, is that really true? I mean, you still have to do a fair amount of, most of the people doing a primary knee, non-robotic also not really doing too much of releases and all that. So you think it makes a difference? You think the inflammatory load is actually low? There have been 3 papers which looked at, they checked the blood parameters and said, but not that that's a ballpark for identifying. But in your opinion, is robotic a minimally invasive surgery compared to a standard knee?
I think it all boils
sorry,
down
for those who don't know, Mahesh works in Deenanath Mangeshkar Hospital in Pune, one of the centers which actually started doing it much, much earlier, and possibly one of the biggest centers doing robotic work. Yes.
Thanks, Gurinder. I think it depends on what philosophy you believe in. If you're trying to use a robot and putting all patients into mechanical alignment and stating to the gold standard of chasing the mechanical alignment, ignoring their CPAC classification, then I think you will end up doing releases. But if you believe in alternate philosophies, if you believe in restoring that patient's native anatomy to a great extent, I think your amount of soft tissue releases will be reduced. And if you accept that you're going to either accept a functional alignment or maybe a restricted kinematic alignment, the releases will be much lesser. And definitely then you are taking the benefit of technology. So personally, I feel if you're using robot, you should use it smartly to make sure that you are restoring that patient's anatomy, reducing resections, making sure that you're reducing the releases, you are creating less soft tissue trauma, then obviously, yes, you are going to reduce the number of releases. But if you chase mechanical alignment for each person, you are bound to do some soft tissue releases.
But are you seeing patients leave early? Are you seeing less analgesic requirement compared to a standard knee which you were doing before, or which you're doing currently?
I have made a very gradual transition. I've been practicing 20 years of mechanical alignment. So when we were introduced to a robot, I did not suddenly jump into alternative alignment philosophies. So we started with mechanical alignment. We then gradually started widening the horizon for us. We started going into adjusted mechanical or functional alignment. I'm using narrow boundaries, so I will not use more than 3 degrees of varus on tibia or more than 3 to 4 degrees of valgus on the femoral side. So I have reduced my number of soft tissue releases. I haven't completely eliminated them.
Sure. So post-op protocols, no different at all? Same?
No,
exactly the same. So Narayan, tell me, is the CPAC classification made any difference to your practice at all?
Two points I wanted to make here. The robotic actually is just a tool. You know, you can do whatever you want to do, whether you have to do a mechanical or a kinematic or whatever the alignment. That's why you cannot say that you are using a robot, and that's why your post-op pain and post-op discharge, etc., is different compared to your normal TKRs. You can do whatever the way you would like to do your knee replacement in a more precise way. So that's all the robot will do. It's a gadget which will help you to do it in precise way. So in my practice, as Mahesh was saying, you know, in earlier part, the first 6 months almost, everything was mechanical alignment only because we couldn't come out of that. The post-op, the management and everything was almost similar. Whereas when we adopted about 3 degree, once we started getting into the CPAC and all other the new alignment philosophies, I think what I have seen is, you know, the soft tissue release has come down definitely. The post-op pain management also has been better, and average the last year discharge time to the this year's discharge is definitely less. So I think, you know, you have seen those improvements, you know, in terms of the discharge, pain relief, and the most astonishing thing what I have seen, everybody, all of us 4 or 5 surgeons, we operate in the hospital, and everybody's X-ray looks same on the next day when you see on the post-operative X-ray.
Perfect. Okay. So we're going to be having more talks on the CPAC classification. So a lot more to learn about that. I think we're just about coming to the end of this. So can we request Dr. Gulati and Dr. Malhotra to please come? So it's just a memento. Thank you so much from all of us for being here. Memento to Dr. Suhas as well. Please give a memento to Vikram.
So just wait.
For the live surgery.
May I request Dr. Rajesh to give the memento to Dr. Gurinder Bedi? So we are going to head up to our next session on basic TKR, shifting goalpost with technology. May I call upon moderators Dr. Mrinal Sharma and Dr. Subhash Jangir upon the dais, please.
Good morning, everyone. I'd like to invite our first speaker, Dr. Suhas, on his talk on CPAC classification and its implications.
Hello, everyone. I've been given the task of talking to you about 2 relatively new topics, which have been the buzzword in the last 2-3 years in most of the conferences. One is CPAC classification, which is coronal plane alignment of the knee classification. And the second one is the alternate alignment strategies in total knee arthroplasty. Both these topics are interrelated, but they are not mutually exclusive because one takes idea from the other. So let us start off with the CPAC classification first, and then we move on to the alternate alignment strategies. So let's go back in time, 1970s, the 2 tenets that the greats, Dr. Insall and Dr. Ranawat gave us is cut your tibia at 90 degrees, cut your femur at 90 degrees, restore the HKA axis to 0, and then you have less pain and long-term survivorship of the implant. At that point in time, implant survival beyond 5 years was a dream. And then at the same time, you had Dr. Hungerford, who said something very opposite. He said, let's cut the tibia at 3 degrees of varus, femur at 3 degrees of valgus, so that you create an oblique joint line, which is more anatomic, and hence he named it anatomic alignment. But no prizes for guessing which philosophy stuck with us in time. Now, 4 decades on, you see that mechanical alignment has reigned supreme, and then it has given promised and it has delivered what promised. 92 to 98% survivorship in 15 years. But is there an issue with mechanical alignment? What is it doing to biomechanics? That is very crucial for us to understand. If you're converting an oblique joint line to a parallel joint line, what is happening? You're distalizing your lateral column. You're raising your medial column. So this creates significant tightness on the medial side, for which Dr. Insall suggested that you do medial release in extension and externally rotate the femur in flexion in order to get balanced gaps. But by the end of the surgery, what are you doing? You're completely altering the joint line obliquity of the patient, and you're altering the constitutional varus of this patient. So the anatomy, the laxity pattern, as well as kinematics of a patient is being altered. We all know that every patient or every human being, even before the arthritis develops, has a different alignment. This was completely put under wraps till 2010, where some of the authors like Stephen Howell, Johann Bellemans, and so many of the other authors came up with 2 new concepts. One was kinematic alignment. Bellemans came up with the concept of constitutional varus, and there were a host of other papers which were supporting both these philosophies. Bellemans showed us that in normal patients, even before the arthritis develops, you have an average constitutional varus of minus 1.9 degrees in men and 0.8 degrees in women. Dr. Mulaji and the other Korean authors have shown that in Indian patients and in Asian patients, this number is even more towards the left. It's around 2 to 3 degrees of varus. So knowing this, what are we doing about it? Hence the concepts of, can we know the native constitutional alignment of a patient? Can we deduce the joint line orientation of a patient? Can we classify it and use this for the benefit of the patients? Many authors tried to do this, Lin, Hirschman, but most of those classifications were very complex with more than 100, 120 phenotypes. Dr. McDessie in 2021-22 came up with this very simple classification, which is known as coronal plane alignment of the knee classification, where he said, let us calculate 2 values, arithmetic HKA and joint line obliquity. And this will give us insights into how to balance these knees. So if you can clearly see here, he defined arithmetic HKA, which is different from mechanical HKA. Mechanical HKA is the angle subtended by the mechanical axis of the femur as well as the tibia, versus arithmetic HKA is MPTA minus LDFA. The difference between the two is joint congruency angle, meaning as the deformity increases, arithmetic HKA doesn't change, but mechanical HKA changes. So the way this classification is defined is, first you calculate arithmetic HKA, which is MPTA minus LDFA. And if you get a 0 value, then you're in neutral. If you get a value that is in negative, then you are in constitutional varus. And if we get a value which is in positive, meaning MPTA minus LDFA, it is positive, then you get a positive value. Hence, the knees are divided into neutral, constitutional varus, or constitutional valgus. On the other side, joint line obliquity is MPTA plus LDFA. If you get 180 degrees, you're again neutral. If you have less than 180 degrees, meaning MPTA plus LDFA is less than 180, you get what's called an apex distal joint line. The way it is nomenclatured is the apices are meeting in the distal. So here your value is less than 180, and if you have more than 180, it is known as apex proximal. So using these 2 values, he divided and created a 3-in-3 grid where you have varus on the longitudinal axis, neutral as well as valgus. And on the other side, on the horizontal axis, you have apex distal, neutral as well as apex proximal. And then they also define some boundaries in terms of how you have to name these. So anything less than -2, meaning -3 is constitutional varus and +3 is constitutional valgus. Hence these numbers came up. So here is an example of a case where you have calculated the MPTA as well as the LDFA. Here it gives you a value of -4 when you -85 from 89, and then joint line obliquity is 174. So this gives you, in terms of classification, you are a CPAC type 1 because it's constitutional varus as well as an apex distal joint line. We have reported the CPAC incidence in Indian patients where we've shown that CPAC type 1 is more common, which is different from Caucasian where type 2 is more common. And many other authors have done so on and so forth. But the most important slide is this. You can see you have 5 knees here. All of them have medial joint line arthritis. The arthritis is pretty obvious. But if you look at the bigger picture, if you see them in a scanogram and then see them with the CPAC, each one of them is different. So it is important for us to know CPAC classification, use it to phenotype your patients, and this is your starting point. People mistake it to be a guide in terms of your endpoint. It is not your endpoint, it is actually your starting point. So that's the end of the first talk. The second talk is about alignment strategies. Here we will discuss about taxonomy because there's so much confusion. Everybody uses the words interchangeably. We've already discussed about mechanical alignment as well as CPAC. So we'll go through the 4 most common alignment strategies that are right now in vogue. In terms of language of alignment, it is important for us to only classify them using these 2. I think if everybody does this, it'll be easier for everybody to understand. You have fixed alignment strategies where you have the same target for every patient, and you have individualized alignment strategies where you want to actually look at the CPAC phenotype and decide what to do in these patients. Before 2006, you did not have many philosophies, but after 2006, you can see there are multiple strategies and philosophies that have been explained. On the left, you have Dr. Insall, where you have 0-0 cuts, and you do a lot of soft tissue releases to balance the knee. But on the right side, you have Stephen Howell, where he said, we will do everything with bone and nothing with soft tissue releases. So here, in this example, Stephen Howell proposed that if I cut equal amount of bone from the tibia as well as the femur to mimic the thickness of the implant, I will recreate the flexion extension axis of the femur. And that's what he did. And then any adjustments that have to be made will be only made on the tibia. For him, femoral anatomy was sacrosanct. And that's how he devised the kinematic alignment plan. Concerns with kinematic alignment was obviously the amount of varus that was being given on the tibia in order to balance these knees. And then came up Venditoli, where he said, let us do exactly the same thing, but let us do it with boundaries. And the boundaries that he suggested are for individual implant positions, instead of being unrestricted, let us bring the boundaries down. So let us do 5 degrees of varus valgus on the femur, and let us keep the HK axis to around 3 degrees, instead of just letting the bony anatomy decide. And then he gave the algorithm. So in your spectrum of alignment, you have restricted kinematic where it is more closer to a HK axis of 3 degrees, whereas kinematic alignment just allows you any alignment strategy. Then came Philip de Grave, who was concerned with the amount of varus being given in the tibia. He said, let us flip the philosophy. Let us keep the tibia constant and let us make changes in the femur in order to balance the knee. So the difference between kinematic as well as inverse kinematic is very simple. In pure kinematic, you manipulate the tibia, and in inverse kinematic, you actually manipulate the femur. So this is the alignment strategy. And the last one that I will discuss is functional alignment, because this is the concept that comes along with robotics. Where they said is, apart from alignment, balance is equally important. So let us develop a strategy which is balance driven. At the same time, let us try to respect the anatomy of the patient as well as the alignment of the patient. So here the implant is moved in 6 degrees of freedom, and you have the liberty to move either the femur or the tibia in order to balance the knee. So this is the main difference between the alignment strategies. What is the boundary? What is the laxity you want to accept? and how you want to change the alignment based on whether you want to move the femur or the tibia. So this is your whole spectrum from the left to right, where you have mechanical alignment on one side, kinematic alignment on the other side. So you need to know your boundaries, you need to know what laxity pattern you want to accept, and you want to know which implant to move in order to balance these knees. I won't go into detail of all the boundaries because it can be really overwhelming, but I want to leave you with two very important concepts. Please understand a malaligned and an ill-balanced knee is completely different from a knee which is natively aligned and you leave some amount of laxity intentionally. The implant on the right will definitely fail because this was unintentional, it is malaligned and not balanced, and that can happen in manual surgery. But it is very different from knowing the phenotype, trying to reproduce that with a well-balanced knee. And so this is how we go around, we go and do our surgeries now. We do the CPAC phenotype, we calculate all the angles, we understand what phenotype is the patient, and we usually use either restricted kinematic alignment or functional alignment in our patients. And we're slowly increasing our boundaries from 2-3 degrees of varus to up to 5 degrees of varus. And then we do leave some intentional laxity, 1 to 2 millimeters in extension and 1 to 3 millimeters in flexion, both on the lateral side. So here is a very a nice case example. It's the same patient where you're simulating functional alignment on the left and mechanical alignment on the right, where if you respect the CPAC phenotype, the alignment strategy, you actually end up retaining the CPAC phenotype and the joint line obliquity of the patient. But if you do mechanical alignment with little releases here and there, you're actually seeing that you're actually changing the CPAC phenotype of this patient, and you would have blunted the joint line obliquity. Is this making a difference in terms of functional outcome? We have very early data from few authors where they're showing that there is a difference. If you maintain CPAC, you might have better patient-reported outcomes. So the take-home message is very clear. Mechanical alignment is still the gold standard, but remember that it does change the anatomy, biomechanics of the patient. If you want to embark on the journey of personalized alignment, you need to understand what strategies that are available, and hopefully they can make a difference. CPAC phenotype classification, it is for you to give, it gives you a guide about constitutional alignment as well as obliquity, and it is used as a research tool and as a starting point. And this is the grid that you need to know. Kinematic alignment is unrestricted with native laxity, and you manipulate the tibia. Restricted kinematic alignment is the same philosophy, but you use restricted boundaries. Inverse kinematic is again restricted, but here you're moving the femur instead of the tibia. Functional alignment is again restricted, but it is more balanced approach, and you have the freedom to either move the tibia or the femur. Thank you for your patient hearing.
Thanks. Thanks, Suhas. Suhas, please be on the podium only because we'll have a panel discussion after the talks. And audience can get ready their questions after the next two talks. And I'm privileged to invite Dr. Rajesh Malhotra, the great teacher and my own teacher, to deliver his talk on the changing shift in releasing the varus knee. Thank you, sir.
Thank you very much, respected chairpersons. Actually, Suhas has really made my job very easy because I just start from where he has left. So the question is, are we still releasing the traditional way? So we know that optimizing the limb alignment affects periarticular soft tissue tension, knee biomechanics, and implant survivorship. Still, there is no consensus on optimal alignment. And we just mentioned this, that there's something called a constitutional alignment, which is a constitutional varus of within 3 degrees, which is seen in 68% patients. And 32% males and 17% females may have even it outside 3-degree varus. So what happens if you leave your knee in varus? Does it lead to increasing varus laxity? Well, no. So in this particular study, which looked at 5-year follow-up, they didn't see any difference in the varus laxity between neutral aligned and varus aligned groups as long as it was within 3 degrees. Again, some of these concepts which have been laid down so nicely with Suhas. And then what he showed you, a classical example. that ligament balance has greater impact than the implant alignment on outcomes. And if you look at the conclusion, it's said in this particular paper, joint balance had a greater impact on outcome than the alignment, indicating that the small intraoperative compromises on component alignment to achieve joint balance may lead in improved outcomes. So you don't have to make it mechanical, and leaving it in varus, the heavens are not going to fall, there is not going to be increased laxity, and then the ligament balance is more important than alignment. And then also the precise ligament alignment balance correlates with better outcomes and less pain, and that has been shown very nicely with a robotic surgery which achieves the balance within 1 millimeter of laxity on the medial and lateral side, and had much higher scores and much higher patient satisfaction. But the alignment is not extremely unimportant. So when we talk about the unrestricted kinematic alignments, it has been shown that if you deviate by more than 2.2 degrees of varus than the native angle, there's an increase in revision rate. And that's the reason why, like Suhas told you, we went on to the inverse kinematic alignment, because you just can't keep on cutting tibia to any amount of varus. So that's the other thing. And the other thing about kinetic alignment is that, if you cut it in more than 3-degree varus, like in this particular paper, then the failure rates are higher, the kinematics changes. And also the slope, which was briefly mentioned. So the posterior slope greater than 5 degrees and high BMI do not do so well with the kinematic alignment, and then you can have failure. So even if you are doing a kinematic alignment, you can't just put the native slope, because the moment you put it in more than 5 degrees, it starts hurting. There have been a lot of classifications about the varus knee with this background, because I'm going to talk about the balance in the varus knee. There's a classification given by Javed Parvizi et al., which talks about intra-articular, metaphyseal, and diaphyseal varus. There is a classification which talks about the primary varus, the double varus, and the triple varus, depending on where the tibiofemoral, how the tibiofemoral geometry is, and whether the lateral compartment is open or not, whether there's a recurvatum. And this is designed by some of the robotic people, less than 3 degrees, more than 3 degrees, and more than 3 degrees with stretched lateral tissues. And I think the key figure of 3 degrees is here because of the reason that if you remove osteophytes, it will actually automatically correct deformity up to 3 degrees. So this is how we have been doing it conventionally. So you do osteophyte removal, and 0 to 3 degree of varus will be corrected anyway. If you have more than 3 degrees of varus, then you go on releasing the posterior-medial release, and the releasing the semimembranosus, even going to that extent. And if it is still you have a patient with stretched lateral tissues and the full varus correction is not accomplished, then PCL is released. So you have to have accordingly the UC trials or the PS option. However, if you are not able to reach your goal even after this, there are certain other strategies. For example, if you have severe varus, which is more than 8 degrees, and you put in a stem, you reduce the risk of failure. So then if you have severe varus, even if you are leaving it in some degree of varus, you should put the stem. You should also use the stem in morbidly obese, whatever, and there again we intentionally leave them in a little bit of varus, because putting them neutral or valgus, they'll rub their thighs together and curse you for the rest of their lives. And then of course the correction of the varus deformity with reduction osteotomy, and we know that with every 2 millimeter of reduction osteotomy, 1 degree of varus is corrected, and then you can even go to the extent of the medial epicondylar osteotomy. So that's how we have done it all along in the conventional way. So we have also, this is a study from Coimbatore, we have also modified how we put our jig in severe bowing of the tibia, put it more laterally when there is a more than 3 degree bowing, again to handle the varus in the conventional technique which we do. So now the question today is, what has changed now? So number one reason which I think which has changed, the fact which has changed is that the measured resection is becoming uncommon and predictive gap balancing is taking over. Earlier in mechanical alignment you had a liberty, you can do gap balancing, you do measured resection, but the measured resection is going out of the way because all the studies have shown that if you cut the measured amounts of bone, you have to do more releases rather than the gap balancing. This particular paper in Arthroplasty today showed that if you did the measured resection, 50 to 53% of the patients had more than 2 millimeter medial lateral imbalance, and 30 to 38% had more than 3 millimeter imbalance, compared to gap balancing, where these figures were 3 to 18% for 2 millimeter and 0 to 9% for more than 3 millimeters. So if you are doing gap balancing, you have to do less releases. And it's not only by conventional method, then it was done by robot. So what about doing these with robot? Even if you did gap balancing and measured resection with robot, the same thing, that 33% releases in gap balancing and 50% in measured resection. And this paper also said the robotic is better than the manual because the release in the manual technique is subjective and is less precise. So we know that when we have predictive gap balancing, there are fewer releases. And this particular paper showed that there were 69% releases in the measured resection technique compared to 33% with the gap balancing. And another paper which showed that almost 70% of the patients needed no release when you had mechanical alignment and flexion gap balancing, and all the knees were balanced using the mechanical alignment in this paper. And they said if you had a varus more than 12 degrees or a valgus more than 6 degrees, then you are going to need the releases. My balance philosophy, this is rather too strict, 2 degree varus to 2 degree valgus, but I would even go to 3 or maximum 4 degrees of varus, but not beyond when it is, when I'm planning. The tibial component, I try not to put in more than 3 degrees of varus, and usually I try to retain PCL as possible. But then we talk about soft tissue releases, remember, the PCL release is a soft tissue release. So all those people who say they use a PS and use a CR and said, I don't do any soft tissue release, there is a release because PCL is a soft tissue which is released. So how does technology help in countering the varus? So first is, you should do your registration after removing all osteophyte. You saw that in the robotic UKR being done, and you always remove the osteophytes, and then based on the varus and valgus stress at the various degrees of movement, you can assess the type of the varus. How the technology can help? We know that the soft tissue damage is less with robot, and another paper which again said soft tissue injury is less. So others said that he is looking at the screen, not even looking at the site, because there is a considerable degree of safety to the soft tissues. But what else does it do? The incidence of soft tissue releases goes down. So when you use the robotic TKR, then 75% patient needed release compared to 46% with the conventional instrumentation, because in conventional, your release is more or less reactive, not planned. You see something and you release. And there is also a poor predictive ability of the surgeon-defined assessment of the soft tissue balance. Another paper, 70% patients needed no soft tissue release, and half of those who needed the release needed only a fenestration or a partial release of the PCL. And 4.5% needed complete release of PCL, and 2.3% actually needed the medial release. And then Dr. Gurva Reddy has described the enhanced mid-resection workflow, where even in the severe deformities, you can actually have a provisional posterior cut, do the releases, so that eventually you don't have to do massive releases as would be mandated by the severe deformities like this, and the patients can do very well without maximum release. So why is robotic, what is so special about robotic that you don't need so many releases? That's because the robotics incorporate the gap balancing data prior to any bony resection. Secondly, you adjust everything by the prosthetic size, the position of the prosthesis, and orientation. Third, you manipulate the implant. And fourth is shape matching to patient's anatomy. So that is how a robot is able to give you a correction of the varus without the releases. And this is the ABC, which is the important parameters of the robotic TK: alignment, balancing, and cuts. So this is just a case example. This is the preoperative X-ray of the patient. This was the functional implant plan, which came from the CT study. And just like others show you very elegantly how to balance by manipulating the component, this is actually after assessing the gap. You can see the 5.5 degree flexion of the femoral component, 3 degree posterior slope, and you move the femoral and tibial cuts proximally or distally, and you capture the gaps. Now the gaps here are 21 and 17, 19 and 16, considerably tighter on the medial side. And then you accept the gap by manipulating the component position, and eventually you have the 18, 17 and 18 and 17, which is within 1 millimeter. So without doing any release at this point of level, after assessing the laxity, you have actually planned where you just cut, and this is what you'll have, and this is the trialing gap, and this is what it actually gave in the final result. So this is how a robot works, and this is how it is able to balance without any soft tissue release. So our way of approaching varus deformity when you are doing robotic is completely altered. And then, how does it matter? The Vigdorchik in his paper has shown that the higher number of patients had less pain if you release. So this is, if you ask what difference does it make if you release less. So they have less pain as compared to those who had pain. There were less rise of inflammatory markers with the robotic knee, and then the overall soft tissue release groups do worse. And the fallacies are that number one, the balance is not always done throughout the range of flexion. They are done at some point. So others sit at 0, 45 degree, 90 degree, 120 degree. Some systems will do at 10, 20, 15 degree of flexion and 90 degree of flexion. But then it has been shown that the precise ligament balance correlates with better outcomes and less pain. So that means that your balance has to be throughout the range of motion, and that's not what most robots are doing. So that's a fallacy. And second thing is, if you use some kind of technology, either a computer or a robotic, to balance and assess the balance and not do it manually. After all, when you are assessing the laxity by hand, it's very subjective how much force you are applying, and every time you have to apply the same amount of force. So that is the fallacy. So considering this, now they are going to be tibial pressure sensors. We can actually show that even if you see that the gaps are equal, but there is uneven pressure on the tibial plateau, it's possible to actually detect it and mitigate it. So to conclude, soft tissue releases are often required to correct deformity. However, that was considered to be an art, which means that something which you acquire or you have a knack for it, it has become a science. It's not an art anymore. You can actually do all that, and overall the soft tissue releases are less with the robotic, and this is possible to quantitatively assess soft tissue envelope before placing real components, and you can actually judge the need for additional bone cup if required, and only in the extreme, like 2 to 3 or 4% you do the soft tissue release. So to summarize, yes, our way of tackling the virus has changed, and the robotics have changed the way we tackle deformities, including the virus deformity. Thank you very much for your attention.
Thank you, Dr. Rajesh. Please take a seat on the dais. We'll have questions after the last talk on valgus knee, video-based presentation by Dr. Rajiv Sharma.
Thank you, Mrinal. Thank you, Ramnik, for inviting to this very well-organized meeting. I've been asked to speak about balancing the total knee arthroplasty in a valgus knee, and some of it will be the videos and some will be the explanations. Valgus knee is a little more difficult for us because because of two reasons. One, that we don't encounter as many valgus knees in our routine practice, and secondly, the release itself is a challenging aspect. Now, you divide the valgus into two, type 1 where the MCL is not elongated, and the type 2 where the MCL is elongated. Ranawat has made a classification addition to the extra-articular deformity to this earlier existing classification, and that is very important, and we'll understand in the next few slides how to do it. Components of the deformity in a valgus knee could be the intra-articular, where you just have the wear of the cartilage or the wear of the bone, collateral frame contraction on the lateral side and elongation on the medial side, and the addition of the extra-articular deformity in some cases. The example of the varus where you have the cartilage wear and where you have the bony wear, which has to be differentiated. The answer is simple. They release posterolateral and unconstrained knee implant. While in a fixed valgus, gross deformity with subluxation, external rotation deformity, probably the answer is much more difficult. You need to do the extensive posterolateral soft tissue release and probably semi-constrained knee implant, or you use the lateral epicondylar osteotomy along with this and use the semi-constrained implant, at least has to be ready. The third type, which is very difficult, is the elongation of the medial collateral ligament, and there you have to have the fully constrained knee like a rotating hinge ready with you, because that is very, very important. Extra-articular deformity can be decided whether you do the correction inside the joint or outside the joint in 1 stage or 2 stage. Which approach? Usually the midline approach, and then you release the medially, release laterally. The example, you must see that sometimes the correction is on the table under anesthesia, and these cases may not need much of the release, like this patient, and you see that it's very easy to correct the deformity in these patients. The first solution is the release of the iliotibial band. The second solution is the release of the lateral collateral ligament and secondary stabilizers. One has to be ready that if you over-release, you may have a laxity. Very important chart here, which depicts that the release, when you are releasing the lateral collateral ligament and you preserve the popliteus is very important. If you release it, what happens is that you have a gross, huge amount of instability in flexion. So that is why what you need to release is not the popliteus but the popliteofibular ligament. Capsule posteriorly, the lateral collateral ligament, but preserve the popliteus tendon. Popliteofibular ligament, that's how you see, and you can release it by the pie crusting the lateral structures. Care not to over-release the lateral collateral ligament because that can be a real disaster. One has to be very, very careful. One example, patient with the bilateral fixed genovalgum, treated with the computer navigation, and now, of course, the robotic has taken over the navigation. You see that the correction with the posterolateral soft tissue release is very easy to do. Another example where you have the stiff knee with the valgus knee on one side, which is a tough situation because this is a huge patient. The weight of the patient matters. The balancing of the joint using a fixed bearing implant, and that's what you see, the function of the patient. Valgus knee with a hyperextension deformity is a much worse kind of a deformity. That's what you see here on the left side. You see the releases, and then you see the follow-up at 9 years with the right kind of the release. Even the longer follow-up, you see that even a mobile bearing joint is surviving very well. Post-trauma valgus knee with a stretched medial collateral ligament and a stiff knee is a far more difficult situation where the joint is almost subluxating. Here you have to be ready with the constrained implant, semi-constrained implant. Here you do the extensive posterolateral soft tissue release and probably a rotating hinge. That's what you see, a patient with the significant amount of genovalgum, and the valgus is corrected by the epicondylar osteotomy, metaphyseal osteotomy. And then you see this patient walking. Another patient of the extra-articular deformity, over-corrected high tibial osteotomy. In a simple way, correct with the osteotomy on the table in the one stage, use the extension stem, and that's what the function of the patient. The deformities could be much worse like this, where you have a severe valgus, stretched up the medial collateral ligament, and contracted lateral collateral ligament in a significant way, and you see that this patient needs a much more assessment. You see the lateral epicondylar osteotomy, where the epicondyle was pulled down. The lateral collateral ligament was released through the bone, and that's what you have the function. Oh, sorry for the sound. That's what you see this patient. So the important pointers that in this kind of a worst kind of deformities is meticulous preoperative planning, slight undercorrection, as has been discussed now with the new alignment strategies, will reduce the need for the release and provide better stability and function. Secondary stabilizers have to be preserved, and it's very, very important wherever possible. Constrained implants in all these extensive lateral, the valgus deformities, constrained implants should be ready because sometimes in spite of your best efforts of the meticulous and careful release, you may still have the instability. So it is very important to have the proper constrained implants ready on the table. Thank you so much.
Thank you, Dr. Sharma, and request you to please be on the podium for the panel discussion, and would invite few more seniors to join the panel. Request Dr. Devinder Singh, Dr. Chandeep, Dr. Narayan Hulse, and Dr. Abdul Ghani to please come on the podium for the panel discussion. So audience, if they have any questions regarding the last 4 talks, they can come on the mic and ask the questions.
I'm sorry I'm here, but can I ask a question? So my question is to Dr. Suhas. We met around, I think, 6 to 8 months ago. At that time, your idea of robotic, or at least to the perception I carried, was that you were leaving the knees absolutely, in my words, tight. Has that changed over a period of time?
Yeah, it has. I think it's been an evolution which is on for the past 2 years. We started mechanical and then we went to functional alignment, where equal gaps in all 4 quadrants was paramount for us, because we were using functional alignment very true to its actual words. But then as we moved our strategy more towards personalized alignment strategies, now we are very comfortable doing a CR knee with 1 or 2 millimeters laxity in extension on the lateral side and around 2 to 3 millimeters of laxity in flexion. So I do remember the first few cases we did, and then I do understand where you're coming from.
See how much the knee needs to be tightened in the extension, flexion and mid-flexion is a very important aspect. Any knee which is tight in extension, mid-flexion and flexion, 90-degree flexion, will be more painful. With the gaining the movements will be more difficult, even if you are doing the non-robotic surgery.
So we had this discussion on table actually.
Yeah.
And I told him, I know Dr. Malhotra has, sir has said a very nice word, balancing the TK was an art which has been taken away by the robot now. But I told him on table that this is tight for me. So we had this discussion, we actually spent 5 minutes on that tightness, so I agree. So my understanding over a period of time, obviously all of us are learning and adapting to the robot. So the question specifically for that was that.
Yeah. The reason I changed also was we were giving varus in the femur to close the lateral side, right? And then I realized a lot of our post-op patients have that lateral tightness, which is exactly what I showed you in those slides of mechanical alignment. And then I decided that's the end of it, and then we try to maintain the joint line obliquity as much as possible now.
Just a quick comment about what is being discussed, also about what Dr. Narayan Husse also said. It is the tightness which will decide the patient will have pain or not, although I did say that the releases cause more pain, more inflammatory marker. Having said that, Rami Suryal discussed with me, they have currently submitted a manuscript where they have shown that the releases, more releases or less releases makes no difference to the patient. So probably that's where, you know, the tightness which you are leaving the patient and those finer things are actually making a difference, and it's not just whether you're doing with robot or without a robot.
Yeah. I think we are back to this, the past. My boss used to say, never keep the knee in tight and never keep the hip in loose. I think, that's where we are again coming back to the 2 millimeter, 3 millimeter.
Can I just
yeah.
I think so far we have not given importance to that milieu interior or homeostasis of the knee joint, which we have done very, very liberal soft tissue releases. And with the advent of robot and with the results, definitely there is something which we do not understand about the ligaments, which includes your PCL, the soft tissue, the posterior capsule, all of them. The less you meddle with them, the better the outcomes. So that's what it is, end of the day. That's what we all learned over the last 3-4 years. And coming to the priorities, the first priority, whether you do robotic, non-robotic, is the ligament balancing. The second priority is the restoration of the joint obliquity if you believe in a non-mechanical alignment, or otherwise perpendicular to the mechanical alignment is fine. But ligament balance takes the precedence over any other thing, because we are going to publish a paper. We have seen around 500 knees of my own, which are 15 years post-op, and of that, 40% of them are outliers. So in other words, inadvertently, I have been doing a functional or kinematic alignment all through, which we never realized that. which we thought it is a mechanical alignment, but it is not. 46% of my own knees are outside the lights. But they're all doing extremely well after 15 years. So the same thing, the paper came from Mayo Clinic. The same thing, they also showed that the alignment is no more this thing. So that is definitely an eye-opener.
Thank you. We'll start with the discussion. So let's ask Dr. Ghani, what kind of alignment do you use in your practice? And then Dr. Hulse and Dr. Chandi.
Well, till now, I think major resection as a main alignment. I don't use, obviously, I haven't used robotic, so it's mainly major resection and gap balancing has to be there, and mainly restoring the alignment per-appropriately on the table, whatever the tightness initially, major resection and gradual release, not aggressive release initially, and based on the tightness intraoperatively.
So you use mechanical alignment?
Yeah.
Dr. Hulse. Now you're using robotics, earlier you used to use
Used to be the mechanical alignment all the time, and very recently we have moved down little and evolution to like about 3 degrees of varus in tibia, and we don't accept anything more than yet, and we have not gone to the unrestricted kinematic or anything of that yet, because I think the philosophy which you have believed so many years, I think that influences what you do for many years until you yourself are convinced that these things are going to be good, and the literature probably has to show more.
Do you believe that kinematic alignment can be done without the robot or the navigation?
I absolutely believe that none of these numbers, 1 degree, 2 degree, 3 degree, whatever the kind of alignment, is not possible without robotics or any kind of at least you should have a navigation to do that. As Dr. Gurwareddy has just mentioned, you see most of his knees, 40% were outliers. It is not because that he wanted to keep those knees in that position. It is because he never had a real measure how many degrees it used to be. He probably wanted to keep that at 90, but it is not possible to measure that. Such kind of sophisticated measure is not there. That's why if you are talking about these 3 degree, 2 degree, kinematic, mechanical or whatever, I think it's almost impossible to do unless you have the technology.
So what about those people who are using the calipers to measure the bone dissection and then telling that it's a kinematic aligned knee?
I think I have done a lot of these the caliper measurements, and we are trying to do few studies using these calipers. Myself cannot measure the second time the same angle or the same measurement with the same degree of accuracy. It's very difficult if you see on a real time.
So that means,
the future lies towards technology only. So let me ask Dr. Malhotra, because he's the senior most person here. So most of the audience, they don't have the robot or the navigation. So what to take home from here? Do they have to buy a robot or navigation to do a knee replacement in future? How they can justify their knee for their patients?
So I'll start by answering and in continuity of what has been said. There's a basic fallacy in everything. Dr. Gurwareddy's 40% outliers were when they were taken in standing weight-bearing X-rays. And when you are doing the surgery, even the robotic surgery, the patient is not weight-bearing. And then you want to compare those and measure those in weight-bearing X-rays, which will take into account the laxity of the ligament. So don't fall for that. Even if you aim for mechanical alignment, I refuse to believe that Dr. Gurwareddy did not get the cuts he wanted in 46% cases. And robot can do that. I'll show you that the robot will also show you the same thing, because robot, you are not measuring the laxity in weight-bearing position. And you are taking all the X-rays for alignment in weight bearings. That's number one. Number two is, if you don't have technology, the best thing to stick with is still the mechanical alignment. The other people are witch hunting for whatever, 20% invest, 10% here, 8% here. I mean, how many people in this hall who do knee replacement and have been doing with mechanical alignment will say that 20% of their patients are unhappy? Can I have the show of hands? It's not, I mean, we are talking from the Western literature. So if you don't have technology, go ahead and do the mechanical alignment. There's no need for technology. This is still not, still I also do robotic. I have done computer assisted for more than 15 years now. But I can tell you that, this is something which people want to. It's like you want to take out a fridge in market every year with something additional. But don't forget that people have been doing well for 25 years with mechanical alignment also. So don't worry about it. If you don't have anything, just go with the traditional way with mechanical.
But just one tibia, even manually, you don't need to bother. You don't need to, the heavens are not going to fall. Yesterday, Suhas recalls, we did a case, extraordinary osteotomy, manual, we did 3 degrees varus cut. But that freedom is there now, which was not there before.
Yeah, I think the point is not to target anything other than mechanical when you do manual surgery.
That's right, because same thing which you said, that if you aim for 3-degree with conventional method, you will cause a disaster when you cut it in 6 degrees, because then the tibia is going to fail and the patient will come back.
I think let's not divide the arthroplasty world into robotics haves and have-nots. And I think you just have to understand what is going on. I mean, robotics is fine. It, you see a value on the screen, 3 degrees virus, that's good. But the bottom line is that human eye and human senses cannot decipher between 3 degrees virus and 6 degrees virus of tibia. If you aim for 3 degrees, you will not realize when it becomes 6 or 7 or even 8. That is the bottom line. So aim for 0 mechanical, and most of the times it becomes adjusted mechanical, whereas you are erring on 3 degrees, 4 degrees. And Mayo paper, and I'm sure your paper will show the same thing, that it doesn't matter so much so long as the knee is balanced.
So are you also keeping our valgus stage into valgus?
That is not something I agree with. It was said, I beg to disagree with Rajiv, but Rajiv can answer that better, because I think the valgus, there is a adage that a knee fails after surgery the way it failed in a primary. So if you leave your, and I think that's why you asked that question, I'm sure. But I will not be happy leaving my valgus in valgus because it might fail. That's a personal.
So the question to Suhas is that this CPAC classification is in the pre-arthritic stage.
Yes.
All the patients come in a deformed, varus or valgus to you.
Yes.
How do you know which stage was it, and how do you reproduce that?
So one of the criteria for the CPAC classification, or the way it was developed with, it was done with no bone loss. Like how the definitions of arithmetic HK and mechanical HK vary. The variance happens without bone loss. The natural evolution for CPAC classification from now on would be to incorporate those knees where you have bone loss, number one, and then to make sure that you're not only looking at alignment, but also looking at balance. So if we can incorporate laxity patterns into the 9 phenotypes, and also understand what bone loss. That is the reason people make a mistake thinking that CPAC is the target. It is not the target. It is the starting point from where either you try to stay in that box or try to deviate the least.
So it's going to change. Definitely it's going to get more refined. And
we are working on so many aspects of CPAC classification along with Dr. McDessie to see how we can improve it. As of now, it's not a perfect science, for sure.
I'll just add to this by saying that, when you see CPAC classification, there are certain groups in which there are very few patients. And we have seen patients with varus, constitutional varus, who don't develop arthritis. There are others who develop arthritis. So it's not just the varus, but the joint line obliquity which makes a difference. So when you're talking about restoring the constitutional alignment, are you restoring the one which led to arthritis? So that's another question which bothers us, because I think eventually we have to look into this, that you have to restore it to that kind of varus which does not progress to arthritis. And we have this. He beautifully showed 6 varices, 5 varices, and each one of them was a different varus. So there are some of them which will lead to an arthritis. The others will not, because you will find very few representatives of them in the CPAC classification in terms of patient with arthritis. I think that's where we need to put more brains and study more to see what is the role of the joint line obliquity in addition to the virus.
So my question next is to
2
Dr.
points,
Subhash.
Subhash, here I'll mention here. What you talked about the non-robotic surgeries that you do. The 2 things if we do, the cross-check our cut, and that can be done with the robot if you are doing a robotic, and also non-robotic also with your extension rod attached to your instrumentation. So you should cross-check for sure, because sometimes you think that you have cut the right alignment, right degree of deviation, and actually you may not be the same. So you must cross-check always, that is one. And second, ensure that you have a stable joint. I think the right soft tissue release, having the stability is probably very important, even if you are doing a non-robotic.
So both these X-rays are...
Also you have to cross-check?
I don't know. I mean, I'm not doing the robotics so far.
Robotics you don't need to cross-check, not at all.
Navigation, you do that.
But navigation, we used to check it up all the time.
Yeah, most robotic systems, before they are validated before they get FDA approval, where they have to divulge the error which is there in the system, which has to be within certain limit.
Robotics, we have done more than 5,000 with Mako.
You don't need
Not a single leave has been out of these things which were expected.
No, actually the
shape matching is so good. Yeah.
And the verification is done before cutting on the saw. You see, we do that just before you cut the saw.
I would like to add just because this is, since it is a basic TKR session, to the beginner, those who are doing number are few. The message, take-home message that use mechanical angle, take soft tissue balancing and right cuts. That's the take-home message.
Yeah, absolutely true. And now the question is...
Can I ask one question, please?
Yes, sir, sure.
Yeah. No, the patients which they come to us, they are in very severe varus or valgus, very severe. So how can you know the pre-arthritic stage in such cases?
So that's
and
the same
can you
question.
do in all cases kinematic alignment in such cases?
So
exactly,
that's the same question, looking at these two axes,
Yes.
both the sides. Dr. Narayan and Dr. Suhas both can answer this question. Yeah. How will you calculate the pre-arthritic...
native one.
Yes. So the classification itself concedes that when you have so much of bone loss, none of these classification systems can be used, number one. Number two, we do these cases with robotics, no doubt about it. But in these cases, we start with a mechanical plan, which is 0-0. We use the feature of dynamic joint balancing in order to release less. That is the only two aspects that we look at. Because ultimately in these knees, we need a stable joint, which is both balanced in flexion and extension. So most of these personalized alignment strategies as of now are not applicable to such severe varus deformities.
I think in the Western world, they do not have such type of osteoarthritis.
Yes.
And that's why they are promoting this kinematic.
No, it's not like that, sir. The whole world is looking at us now. In fact, afternoon I'm going to show you the role of robot in gross deformities.
Together with Alfred Triad.
Yeah, in fact, the whole world is asking us
yes.
to validate the robot in the gross deformity.
So my next question, suppose you have a choice of all robots, this Mako and this Cori and others. So what will you try to prefer that robot? What will be your preference?
I would use...
And why?
That is the last session in the afternoon.
We'll have this in the next session. Let's take the...
No, this is a very important question because I am going to buy a robot.
Next session.
We have a session on that in the evening.
You make up your mind in the evening once you've seen all the robots.
You will be very busy in the lunchtime. All the companies will be after you since you are going to buy one.
So Suhas, you are somewhere between the inverse kinematic and kinematic alignment, right?
Yes. So our strategy right now is functional alignment, but we start at a restricted kinematic plan. So that is what we normally do.
So function is somewhere between the kinematic and the inverse kinematic.
So we are more towards, you don't have, it's restricted kinematic and not inverse.
Between these two.
Yeah.
So regarding the varus release, Dr. Malhotra sir, you must have seen that we were doing all these releases before this era came. But even without the robot and navigation, have our release gone down significantly? What is the reason behind that? Not everyone is using the robot and navigation, but still the releases are less on the medial side.
Releases are less because people are coming for treatment relatively earlier. The smaller proportion of patients are now coming. And even without robot, you can do minimal releases in a severe deformity just by doing an epicondylar osteotomy. You do an epicondylar osteotomy for valgus, you don't need to release anything. You do for varus, you don't need to release anything. So it's only when you see a particular patient and you assess, you have to decide what strategy you are going to follow. And the releases are less because people are aware of strategies like I showed, the downsizing the tibia, lateralizing it, and doing the reduction of osteotomy. All these things will, people have become aware that it's important to remove tenting of the ligaments. That's where the paper from Dr. Gurva Reddy comes, that even a robot has to be guided properly. So you can't assess when there are big osteophytes impinging on the posterior capsule, you can't assess the extension space. So that is why I think the ligaments have to be completely decompressed before you start doing your work.
So Dr. Malhotra, this case on your left, what would be your order of releases and till what extent would you go and what would be your last resort if you're not able to balance?
Other side.
So if you want to do it with the robot, you have to refer to Dr. Gurva Reddy's technique do provisional posterior cut with a robot, release the osteophytes from behind, and then reassess and rework on the ligament tension and do it. That's the way to minimize the releases. If I were to do it the conventional way, I'll straight away release it all the way posteriorly. I'll release the PCL right in the beginning, and I'll remove all the osteophytes, and then I'll do a measured resection and then balance it as it is required. That's the classical, including the reduction of osteotomy or lateralizing the tibial cup.
So I have taken a conservative tibial cut. I have done my reduction osteotomy. I have
that is the key in these
lateralized
cases.
the tibia. Still I am not able to balance. What next?
So that is what you have to decide how severe this is. If it is too severe, you should think about a medial apicollar osteotomy rather than doing the whole lot of releases and then doing the osteotomy. So if you think it is something after your previous initial exposure and all, and you see how much correction you have achieved by removing the osteophytes and by doing the posterior medial release, rather than going too far into it, you can do medial apicollar osteotomy. But if that doesn't work, see, what you are asking is you have done everything and you can't balance it, you have to do a medial apicollar osteotomy. There's nothing else. You've done a reduction osteotomy, you have done a release.
When do you decide on table that I should directly go for a medial apicollar osteotomy rather than not doing the release initially? Like in a valgus, you initially can go for an apicollar osteotomy. In a varus, it's a little difficult to judge.
That's right. That's right. That's actually, you are absolutely right. In a valgus deformity, you can decide on right from the incision that I'll go and do a lateral apicollar osteotomy. But what situation you are saying is also hypothetical, because very rarely you have a situation where you are not able to balance it at all, and then you have to decide upon medial apicollar osteotomy, because the medial apicollar osteotomy is done much less often than the lateral, because it is easier to balance a varus than to balance a valgus, and the need for apicollar osteotomy is much more in the valgus or in the varus. But I think you anyway have to do initial release of the medial capsule in all exposures to get the tibia forward, only that you will do a little more liberal. But rather than release, and PCL has to go in a severe deformity. Now, whether you want to do the semi-membranosus release and everything, or you want to do a medial apicollar osteotomy, is what you are going to judge on the table.
So, since it's a basic knee session, we'll just finish with the last question. Sorry.
If you just see the X-ray of your patient, can you just go back to your X-ray? And you see that there is a bowing, metafacial bowing deformity in the preoperative X-ray. So these are the patients where you know that the release is going to be very difficult, and you have to be prepared. And as has been discussed, it's right that tibial reduction osteotomy, even before the release of the middle collateral ligament, I think is a very, very useful tool.
So since it's a basic knee panel discussion, so there's a video on the right side of your screen. You can see that after taking the cuts, the person has reached the stage where the knee is opening up laterally in extension and flexion looks decent. So start from Dr. Rajiv to what to advise to this person. He has sent you a video on the phone. Sir, I am stuck here. What to do?
And do we have the preoperative X-rays of this patient?
So he has sent you this video that intra-op is a varus knee. He is stuck in a situation where the medial is tight and extension. It's opening quite significantly on the lateral side. And flexion looks quite good.
The first thing is that you need to cross-check your cuts, whether the cuts are appropriate or not, and you want to make any deviation from the already existing cuts. And even then, if you have the laxity, and there's the lateral laxity, that's what we can see.
That's the lateral opening up, laxity and extension.
So you need to see with the transepicondylar axis whether your rotation of the femur is right or
all
not.
Okay.
In such a situation, The best, because this is about 3 millimeter laxity, 3 or 4 millimeter.
Looks quite significant, 5 to 7 almost.
I would simply rotate the femur more laterally by 3 degrees, and this imbalance will be corrected.
You have taken all the cuts and the rotation is fine. Would you still like to
This
go
is
back
an
and
extension.
change?
It's lax in extension, flexion it is
Not in
balanced.
flexion. Flexion looks
extension. I can't see from here. I can see the laxity in the medial side, lateral side, flexion also.
I assume this is a pure lateral laxity because the flexion is balanced, so no question of femoral rotation comes here. And if I see that on the medial side, on the proximal tibia, I'll make sure that it is fully released. I don't know whether it's fully released or not, up to the posteromedial corner and the posteromedial capsule, and also take the positive parts if any. And after that, my still, if it's still loose on the lateral side, and making sure that there is no lateral collateral ligament issues, it is not cut or anything of that kind, which is very, very rare. I will go for a reduction osteotomy. That's my next step. Even if it is not balanced, and even at that stage also, we have a next option of a pike crusting if you want to do. The pike crusting is, some people won't like it, some people routinely do it. I do in a very rare cases with the needles only, so that I'll get the little release on the medial side. Even after that, if it is not good, or maybe before that, if it is a huge deformity still left, we can go for the medial epicondylar osteotomy.
So the order of releases has to be gradually increased and then go to the posterior middle corner. If you're not able to get the releases by your lateralization and reduction osteotomy.
And I usually avoid distal release.
Okay. So you can go in and do a epicondylar osteotomy like I did in this case. And you can see that on the right side, I actually needed a epicondylar osteotomy. Despite my lateralization, you can see the tibial keel is almost sitting on the lateral cortex. And I could manage to do that. But on the left side, you can see the reduction osteotomy is almost to the parallel to the cortex, on the medial side. A huge reduction osteotomy done, and I could balance it. So you have to gradually increase your releases and then see what is needed on table, and the last resort can be, the epicondylar osteotomy.
I think the reduction osteotomy really works well if you have tightness both in flexion and extension. Yeah. Because you can do that big reduction where you account for both flexion as well as extension issue. But if you have, like in that situation where it was more posterior, reduction might not help because it will open up your flexion also. Most often than not, it is surgeons who are hesitant to do that big semimembranosus release, remove all the osteophytes. And then the lateral laxity that you're seeing is actually induced by the medial tightness. And it's not lateral laxity per se.
Yeah.
And the other thing which helps in these patients is, particularly if there is a flexion deformity, is to strip the capsule from the posterior femur. And then the posterior capsular tightness on the medial side is also taken care of. So forget about your greed for or love for PCL. I would just remove the PCL completely and then strip the posterior capsule off the femur. And that also will give me some relaxation in extension.
So before we close, the last question from Dr. Malhotra. As the robot is catching up, do you see there will be a short learning curve for the newer surgeons to learn the nuances of knee replacement?
Of course, there is the learning curve for robot is much less than the conventional thing. So only thing about the learning curve is the time you take for the surgery. But the precision or the planning doesn't have much of a learning curve. So but my sincere advice is that everybody must learn it the conventional way, because the pin can become loose, the things can go wrong, the machine can hang. If you don't know how to do a knee replacement the conventional way, don't try to do it with the help of technology. But then, of course, the learning curve is not much.
Conventional has to be learned by everybody. We all agree with that. The one thing what I have seen in my daily practice is that if I have to give a case to my fellow or a junior, it's easier to give him a robotic than a conventionally on that day. Because you know what exactly he has done on record, and he will also know the live feedback, what exactly happening at each stage. So in my practice, it looks like the training and learning is probably easier with Mako than with the conventional things. Because he gets the live feedback each time, and his mentor or a teacher gets at the end of the day what exactly has been done on each case.
Yeah, we have a very large fellowship. We do 15 fellows every year. And then now with the combination of both robotics as well as conventional surgery, their comprehension of how to balance a knee is much better when they visually see what happens when you maneuver the implants and then what releases you do.
So I'll give you an example. When we started doing navigation, we realized that the distal femoral cut is very often in extension. It's an extension, which you never realize because the blade skies. It was only that when we checked the distal femoral cut, we found that the inferior part was not being cut properly. And after that, whenever we did the conventional, we made a conscious effort to actually take away bone from the posterior condyle of the femur when the knee is flexed so that it is not extended. So I think everything is a learning experience if you just keep on paying attention.
So the message clear that need to learn the traffic rules first before start driving, right?
See, one thing, Subhash, that we should from this discussion, it should be understood that though I understand that a lot of surgeons are using a lot of robots, the robotic is not the only way to have a good surgery, good results. Of course, if the better technology is available, you can use it. And at the moment, we are still in the process of understanding the results of the robotic, and long-term results will be coming after a few years. The second is that the right kind of the surgery is probably the most important issue. I think that is the message that we should.
So in the interest of time, I'll just conclude from here, and I'll thank all the panelists and my co-moderator Mrinal for conducting the session. And thank you all.
Thank you, everyone. I'd like to invite Dr. Rajesh Malhotra to please honor and facilitate Dr. Rajiv Sharma. Please. Dr. Malhotra, sir. I'd like to invite Dr. Davinder Singh on stage, please. Dr. Subhash to... Dr. Chandeep. Dr. Subhash. Dr. Narayan. Dr. Abdul Ghani. नहीं डॉक्टर नारायण से पहले डॉक्टर नारायण उनको दे दो पहले थैंक यू जी ओके थैंक यू सो मच थैंक यू
So we are actually 10 minutes behind schedule. So let us move to the next session of complex primary TKR. So may I call upon Dr. Simon Thomas and Dr. Narayan Ulse to moderate this session.
Good afternoon, everybody. I think without further ado, we'll get the first speaker. Dr. Vivek is here? Yes, sir. Sir, please come on. He's going to talk about stiff and fused knees.
Good morning, everyone, and thank you, Ramni, for having me here. This is something I've been talking in the very same forum. I think this is the third time I'm talking, but today I've included a few more cases for the benefit of the younger surgeons. I'll be restricting this talk to complete bony ankylosed knees, and it is not a didactic talk. It's just about a few cases to zero into the fine key surgical tips that I'll enumerate at the end. So start with the first one.
This is a case of fused knee in flexion valgus and external rotation. Young fellow, about 35 years. Post-traumatic one, about 10, 12 years old. And that's how the x-rays look before surgery. And this is at the time under anesthesia. Complete bony fusion. So the first thing is a long medial parapatellar skin incision, not a midline one, because later on the flexion produces a lot of tension on the stitches. A thorough quadriceps release is essential way up to the proximal thigh, and then we move from the proximal to the distal portion, from the normal to the abnormal, to identify where the patellar bump is, because that is the key point. And then infrapatellar fat release is done. This thing, This infrapatellar fat pad is a fairly constant thing to see, and it helps us identify the inferior portion of the patellar bump, because that is where you are going to make a patellar osteotomy, unless the extensor mechanism itself is ossified. And then another key step is to osteotomize the patella with a saw. Earlier we used to do with osteotomes, and several times the patella used to break into fragments. And then if you have done a good infrapatellar fat pad release, then we are able to translocate the extensor mechanism laterally, and it's completely continuous from proximal to distal aspect. And you see that there are the flaps, this soft tissue flap is continuous from skin to the bone. We've not raised separate flaps. A good amount of lateral gutter clearance is required. And then you usually see a bump between the femur and the tibia where the joint line is. And then multiple and multi-directional bicortical drilling needs to be done. Your assistant should not put the counter hand on the posterior aspect, because that brings the vessels closer to the field. Very sharp osteotome, almost like a corticotome, is required to join the holes that you have made, and it should go way almost up to the posterior cortex. And if you have carefully inserted your osteotome in all the directions, then you see the breaking point comes. The osteotome should not be removed in any superior-inferior plane. It should be removed in the same plane as it is inserted. That is another key point to avoid inadvertent fractures. And then another important thing is to, so now the osteotomy is complete. Another important thing is to take out a neat cake of bone from the initial point of osteotomy. So this gives a decent amount of space for us to work on, and then the knee can be flexed. So these are the key points to see, to open up the fused knee. And as you see, the whole quadriceps mechanism has been translocated laterally. There is no need of eversion of patella at any point of time. In fact, we don't evert patella in any given case. And then the rest of the procedure is as usual. In this particular case, lateral collateral release and hamstring tenotomy was required to correct the flexion and the valgus. And this is another key thing. We must decompress the patella as much as possible, because every millimeter of patella thickness which is reduced will add to more flexion. Even if it amounts to a near total patellectomy, doesn't matter. The patients end up recovering with good quadriceps function, as you will see in a while. There is almost no need to retain the whole of the patella. Just a flake of the bone should be enough. And as you see, after trial, about 90 degrees range of motion is there available on the table without a quadriceps snip. So then, I'm sorry, this thing just moves on to the next video every single time. So this is the post-operative 1 month. These are the post-operative X-rays. And another case, this is a follow-up of the same patient at 7 years. Yesterday only I got a video on WhatsApp from this patient. Good range of motion and good quadriceps strength. Another case, a similar bony ankylosis. Just to bring another aspect here, these were the earlier days when we were doing the osteotomy of the patella with the osteotome, and sometimes the patella used to break, and that was the time when I realized that even if I remove all of the patellar bone, it will actually not matter. So this is many years ago. Similar technique, and about 100 degrees range of motion achieved on the table. Good stability. This is after closure. Medial long parapatellar incision is the key to avoid tension on the sutures later on. Drop test, post-operative X-rays, gravity-assisted 90-degree knee bending in a few days, walking, stair climbing. You said the same thing. You've seen this case earlier. Yeah, and I do not have his latest videos, but this guy sent me a video 1 year later that he was able to completely touch his thigh to the leg at 1 year, and this was a case with near total patelectomy. So losing patella does not matter. Another case, a different kind of a case. This guy was a 38 years, I'll just take 2 more minutes, 38 years male with multiple surgeries done for trauma, and he already had a brachial plexus palsy. This was the state of affairs. Femur and tibia have implants there, and the extensor mechanism is completely ossified. So what we did was, we osteotomized the patella with a saw there and carefully removed the infrapatellar bone piece by piece, saving the soft tissue layer on top of it. And this is the final picture. 90 degrees knee bending at next day, and some amount of quadriceps activity happening there. And it's surprising to see that the patients who have a fused knee also recover a good amount of quadriceps function a few days later. And this is how the patient was discharged, walking with a brace. And this is the picture at 6 weeks, a decent amount of quadriceps activity, able to walk without a brace and able to do negative quadriceps also, climbing downstairs also. So the key surgical tips to summarize here are that the skin incision should be long, really long, and medial parapatellar, not midline. We have to make a long arthrotomy proximal to the quadriceps. We have to raise full thickness flaps. Thorough quadriceps release is the key, and we can avoid a snip or a VY-plasty there. And we should move from proximal thigh towards the knee. Infrapatellar fat pad is the key landmark to identify the patellar button. Patellar osteotomy should be done with a saw, and we must decompress patella as much as we require to gain at least 80-90 degrees range of motion, and we can accept near or total patelectomy if required. Thank you so much for your kind attention.
Next talk is by Dr. Yetendra Karvanda on stress fracture.
Thank you, Chairman Sir, and good morning to all of you. These are my disclosures. So, coming to this case, the first case. So, generally we see stress fractures in gross, varus, or maybe valgus deformities. Generally varus, because we see a lot of them. I mean, varus is the most common deformity that we see. Osteoporosis, rheumatoids. So here this lady came with this X-ray. And can anybody see a stress fracture? Where? Now that you know that the topic is that, but yeah, but I'll just show you this lateral. Now you can see, I know, because it's a topic is this. But what I want to stress first here is that this was 6 months ago. So always, get a fresh X-ray. Many times, we operate with the old X-rays. Don't do that. And this is of course, the clinical picture. And this is what when we did the fresh X-ray, there was clearly the stress fracture was seen. Now you can see that stress fracture was there earlier. So these are dealt with the long stems, and I'll come to that and elaborate on this. So this is obviously a complicated primary TKR, all of these because there is a varus deformity, severe varus deformity. You have to deal with the bone defects, you have to deal with osteoporosis, there is an insufficiency fracture, you have a problem of bilateral issues, bilateral knees, because if you are doing a complicated case, whether you would do a bilateral, generally these are elderlies, and if you do just one, again, you won't be able to mobilize them very well, and there may be a medical problem. So it's obviously a complicated problems. And this was a classification done by Mullaji in 2010, and he classified these fractures as intra-articular, extra-articular, again, malunited, ununited, impending, acute. This basically tells you the treatment modality which you can decide preoperatively. So I will elaborate on these issues. Is long stem sufficient, or do you need more augmentative procedures like proximal femur resection or osteotomy, plating, bone grafting, whether you need all these things? Should both stress fracture and knee arthritis be addressed simultaneously, or you should do it in stages? And we should have a unified algorithm to treat this. So there are risk factors, as you know, severe knee arthritis, obesity, osteoporosis. 1.3% of these patients with knee arthritis have stress fracture. This is the reported incidence in the literature. And when I went through the literature, most of them, more than 95%, I would say probably all of them were literature from this part of the world. Probably, Western people don't see that because they come for its timely treatment. And generally, stress fracture is as a result of altered weight bearing with osteoporosis. 80% are women, and we see 92% in osteoarthritis and 7% in rheumatoid. So these are the augmentative procedures. There is a lack of consensus as yet whether we should be doing this, in what cases. It is all dependent on the patient's, what type of patient you are dealing with, what is the deformity, what is the osteoporosis level, and the surgeon himself or herself. So fracture stability is the most important, whatever you do, and that can be achieved in multiple ways. Long stem has to be there, plating plus or minus bone grafting, proximal femur resection to get compression at the fracture. Malunions may need closed wedge osteotomy, and non-unions will need debridement with probably segmental fibulectomy. So these are the various augmentative procedures. Now this is a lady who's almost 81 years old. She first had a fibular stress fracture which healed, and then she came up with a more acute stress fracture of the tibia. Now this was a case
which I don't have the long length because they couldn't do it, but this was the one which had a valgus deformity. Generally we see in various deformities. So here, as you can see, long stem was used. The only thing about the long stem that you have to remember is that it should cross the fracture, obviously, and it should be at least 2 cortical distances. And some of the implants, I mean, if the fracture is a bit lower than just upper third, you may need a longer stem, which is, some of the implant companies don't have that. This was a case with acute fracture. Here you can hardly see any callus, and here we had to use an augmentative procedure like a plating, which was again done percutaneously, but then there are some risks of these, more skin necrosis, and sometimes a stress fracture can develop even below the plate. So this is one in the literature which I got, a systematic review of single stage long stem total knee arthroplasty, and according to this, conclusion of course is that the long stem is the mainstay and augmentative procedure may be used, and this is the excellent way to treat it. Implant design here, because you are going to cut the PCL because of the extreme varus deformity, one should use a posterior stabilized, and for the purpose of people who are doing this in their early years, you should stick to posterior stabilized because it has a good track record, and you are sure about the movements and stability. Stem length, as I said, it should exceed the fracture site by at least 2 cortical diameters. Whether you do a cemented or uncemented, but the basic thing is that the base plate of the tibia should always be cemented. And most important, which everybody agrees, is that cement should be prevented from entering the fracture site. Time to union, again, this has not been said in this literature here. No literature has said that, but generally it is about 7 to 26 weeks, depending upon whether it was caught in the early stages and whether there was some healing going on. Rehabilitation protocol is that full weight bearing from post-op day 0 can be started if you have achieved good stability. But if you are slightly wary about the stability, then yes, partial weight bearing for 4 to 6 weeks. Mobile fractures, which are acute fractures and very mobile, and you may have used plating, then you should do non-weight bearing for 4 to 6 weeks. Range of motion and quadriceps strengthening should immediately start. Another thing that you have to take care here is of bone defects, which I generally use titanium mesh with cemented with impaction bone grafting, because again I can do early weight bearing. So these are some of the illustrations here. In conclusion, what I would say is that long stem TK is an excellent option and is associated with excellent outcomes. Augmentative procedure may be used according to the type of the stress fracture and according to how the patient's condition is. PCL should be sacrificed to correct the deformity and hence a PS implant. Early detection and intervention would obviously prevent disease progression and deformity, and there should be no distraction at the fracture site. Thorough clinical examination, labs, everything is essential. Thank you for your attention.
Can we Dr. Hemant Bakankar, sir, please? Dr. Hemant will be talking on TKR after osteotomies.
Right, thank you very much. I'm taking over Dr. Mahesh Kulkarni's topic. Would like to thank Dr. Ramnik and his team for this kind invitation. My brief is to talk on post-osteotomy TKR, and we're essentially talking about the proximal tibial osteotomies. Now, high tibial osteotomy has been extremely popular with especially closed-wedge high tibial osteotomy has been very popular with the earlier generation of orthopedic surgeons. Today, it's not so popular or not being done. It has been a good surgery and is very useful in a correctly chosen patient. It does work well for maybe 5 to 15 years. That's what the literature suggests. Unfortunately, there are two major problems with proximal tibial osteotomy. One is patient selection, and second is it's a difficult surgery to execute it perfectly. I can show you disasters after disasters of high tibial osteotomy that have gone wrong or done badly and have just very poor outcomes as a result. And in effect, what happens to us is we are either left with a knee that is still in varus, the deformity still remains, the knee remains in varus, or in many situations, it's an overcorrected high tibial osteotomy. And both these situations create extreme problems when it comes to total knee arthroplasty. I believe overcorrected high tibial osteotomy is one of the most difficult or challenging propositions during to do a total knee replacement with ligament balancing. So the end result of high tibial osteotomy many times is persistent varus, or it could be overcorrected into valgus. The tibial intorsion is a major problem, especially with these closed wedge osteotomies. Many of these legs used to be in internal rotation in plaster, and tibia remains in internal rotation. The scars may be unsuitable for surgery. Most of these patients have patella baja with infrapatellar fibrosis. Implant removal could be a challenging proposition in some of these patients. And tibial slope does get altered, especially when the osteotomy has been closed with osteotomy. As you can see in the top right corner, there is practically no tibial slope here, and that has to be addressed, and that can be a major issue. Many situations, there is medullary canal distortion as well. I'll show you examples of that. So the scars of the high tibial osteotomy. This is a lateral scar that is not going to be a problem for surgery. And even a longitudinal problem, scar is not a problem. Transverse scar again is not a problem unless it is really puckered at the level of the tibial tubercle. So you can straight away go through a midline incision without any subcutaneous dissection, and that is not a problem. Problem comes when you have this kind of a scar in an obese patient. And these patients, if you take the proximal limb of the scar, it goes laterally, and that is not suitable for knee. So you really need to develop incision like this, go perpendicular to the scar and go all the way to the fascia without any soft tissue dissections. And this kind of situation works very well if you do not do any subcutaneous dissection. I can show you many examples. If you leave a bridge of skin between the two scar, the previous scar and your incision, this is not a problem. Or you can do, as I've shown, taking care of the angle between the old scar and the new incision. And this kind of approach does not create any problems with the soft tissues. Now, persistent varus situation, with alteration of slope is a concern. And as you can see here, the slope is virtually, maintained here, because if you try to give a normal slope, for example, this is next gen, and this demands 7 degrees of posterior tibial slope. If you give that kind of slope in this implant, you're going to have severe flexion instability. So you have to actually go for the native slope and try and match the native slope when you're doing the tibial cut. This patient, for example, has a significant varus deformity, and many of these implants that are there, if they're not coming in the way of your implantation, you can certainly leave those behind, and you can complete your surgery with those implants in place. Only if the screws are coming in the way, like a medullary screw here, you can take the screws out, leave all the metal work behind, because that's all buried within the bone. It's difficult to take it out, and you can complete the surgery. Let's come to overcorrected high tibial osteotomy now. It's basically a big problem when you have overcorrected high tibial osteotomy with altered anatomy. The femur is typically of a varus, but on a tibial side, tibia has become a valgus tibia here. Now, if you consider the long axis of tibia and cut perpendicular to that, you realize that you're going to excise a lot more bone on the medial side. You're going to be left with a defect on the lateral side. This is exactly what would happen typically in a valgus knee, not in a varus knee. So you actually take out a lot more bone on the medial side than on the lateral side. Patella baja is a problem, so is the tibial slope. And effects of excessive tibial medial resection is that you have an extension gap. You may require to do a lateral release like you do in a valgus knee for getting your rectangular extension gap. And in flexion side, even 3 degrees of femoral external rotation is going to give you significant medial laxity because you have taken out too much bone on the medial side of the tibia. And in fact, flexion balancing becomes a big problem. Many times you have to actually keep the femur in zero rotation, neutral rotation, not 3 degrees or even higher. So patellar tracking can also become a problem if you put the femur in slight internal rotation from the usual. Lateral popliteal palsy is a serious complication for overcorrected high tibial osteotomy. And I'll show you an example of this case here now. This is what the resection is going to be. You're going to be left with defect on the lateral tibial plateau. So this is after I've taken my tibial collat. You can see that there is no bone resected from the lateral side. So that area needs to be grafted. That was grafted with a bone graft here. And that is a post-operative X-ray with the graft and screws in situ. And this was obviously a posterior stabilized knee. Many of these overcorrected high tibial osteotomies actually are fixed and certainly, require huge lateral releases, and many of them, in fact, require a constrained implant, as you can see here. This is the LCCK used for fixed overcorrected high tibial osteotomy. Another example of the same, it required grafting on the lateral side along with a constrained implant that had to be used here. Many of these patients have medullary canal distortion, as you can see here. If you try to use a normal tibial implant here, it's going to hit the lateral tibial cortex. You're going to have a fracture there. So in fact, I had to import a small keel tibia. This was done many years back, and this is what the implant that was used. Now, this small keel tibia has been withdrawn from the market, but this patient has done very well. I think I have had a 15-year follow-up recently of the same patient, and she's still doing very well. This patient had this high tibial osteotomy bilaterally about 1 year prior to consulting me. On the left side, she actually had a non-union of the high tibial osteotomy. And both these knees, you can see, they were completely unинdicated with wrong patient selection for high tibial osteotomy. Now, on the left-hand side, you could not work out whether there was significantly hypermobility at the fractures, at the osteotomy side. And I had to, on table I realized that in fact lateral ligaments were incompetent as well. So I had to go ahead and use a constrained implant for this. I did not open the osteotomy site itself, but bone grafting was done within the tibial preparation. And this osteotomy united in a matter of 4 months. That is the 4-month follow-up of the same patient. Results of result of TKR after high tibial osteotomy, just some literature review. This is an old paper that suggests that it had previous high tibial osteotomy had no adverse effect on the outcome. But there are many papers that suggest that it significantly reduces the flexion. It has higher reoperation rates. There are many failures, and they tended to be in medium to long term. This patient from Ashok Rajgopal's series also suggested that soft tissue balancing and malalignment needed to be taken care of. So to take home message in this topic is that we really need to anticipate intra-op difficulties. Patellar eversion is difficult with patella baha. You need to avoid medial releases. Posterior slope of the tibia does need attention. Medial laxity that you end up with can be a significant problem. May require release on the lateral sides to balance the medial laxity. And tibial component may actually needs to be medialized in deformed tibia. Thank you for your attention.
Next talk is by Dr. S. Gulati on management of bone defects.
Is it on? Good afternoon, ladies and gentlemen. Thank you for giving me this opportunity to present this. The secret to long-term results, no matter whether we are using robot or navigation or nothing, basic remains the same, that we have to restore some kind of either mechanic or kinematic or whatever axis we need to achieve that. We also must achieve soft tissue balance, but at the end of the day, we must have a base which is stable, on which we can implant this. If the base where we are implanting these is not strong, nothing is going to hold. So that is what it is. So if there are bone defects and we are trying to put implants on top of that, no matter what strategy we are following, is going to fail. There are a number of classifications which have been given for bone defects. This is the commonly used AORI classification, T1, T2, T3. I'm not going to go into the detail on the tibial and femoral side. Suffice it to say whether it is one condyle involved or both, or whether metaphysis is intact or not. So, I mean, we'll not go into the detail, but this also, whether it is a surface defect, cavity defect, or segmental defect, again, we'll not go into detail. But suffice it to say that we need to, at the end of the day, not memorize this classification. That's why I'm not going to spend time on that. at the end of the day, when I'm on operating table, I need to decide whether this defect is contained or not contained, and what is the extent of this defect. My treatment strategy is going to depend on that and not on T1, T2, 5, F4, 5, 5. I'm not interested in that. So that is what is important, and my treatment options are going to be either I can alter the bone cut, I can use cement or screws, or I can use bone grafts or metal augments. Tumor prosthesis in primary situation will be extremely rare unless it is a very badly fractured bone before. So altering the bone cut is a very simple option. We do it every day because either you take 8, 9 or 10 millimeter from the healthy side and you go to 2 millimeter below the more involved side. You can make it a little more or less, and you can convert an uncontained defect into a contained defect by just altering this line. But that's for very small defects, not big defects. If we remove too much of bone, then we are altering the joint line. So never more than 1 centimeter, even 1 centimeter would be more. So I think the better strategy would be to remove, say if you are using the lateral side and using conventional instruments, 10 millimeter or 9 depending on the instrumentation on the lateral side, and then see what is left and then manage that defect accordingly. This is, gives you the picture of an appropriate and inappropriate resection. To removing too much bone, we go to unhealthy, very soft bone, and then chances of failure are high, and altering joint lines, that's not a good thing. If the defect is less than 5 mm, we all know that we can compensate it by only cement. Just make a few drill holes there and let the cement do the job. And this is just an example. If the defect is between 5 to 10, what we can do is we can put screws, 3.5 mm screws, just a little short of the tibial plate, and then let this cement and screw construct do the job, and usually it does well, and all of us are doing it as a routine, and we face the situation almost as a routine. Now, if the defect is bigger, then these strategies are not going to work. Then we are going to need either a bone graft or something different than that. We can use a morselized bone graft if the defects are contained, or even if it is uncontained. I will show you a picture later, and Jatin also showed it, that you can use a wire mesh and do impaction bone grafting and use that. Or in these contained defects, you can use a morselized bone graft and put in there, and this is how it is done. And this is an example, and you can use a small bone block and fix it with a screw and then plate on top of that, and you can see the deformity correction after that. And this is an example on the lateral side. You can see the deformity is corrected with bone grafting. Now, there are obviously strategies for that. You have to, if there is a sclerotic bone defect, you need to clear it out, make it good for bone graft to get incorporated there, and if you are putting a block of bone on that, then the screws have to be done perpendicular to that rather than oblique, and use screws rather than wires, and these strategies have to be followed. And as it was shown by my colleague in my hospital, you can use wire mesh and an impaction bone graft there, and that gives excellent results. Important thing is that if you're using a large chunk of bone or bone graft, especially in bone uncontained, is better to augment it with a stem in that, to offload that area for that to get united. So I already have enumerated these points. So coming to bone graft is available when you're doing the surgery. There is a lot of bone coming from the lower end femur. You can use that. It'll most probably, it'll get incorporated. And if, especially the patient is younger, if revision is required, there is a huge amount of bone stock that you have made again. And these are the advantages. But the disadvantage is that sometimes they may not even get incorporated. And then you are left with, an implant which is not supported by bone, and then they get resolved, non-union, and then we are in a difficult situation. But that's few and far between. Mostly they do get incorporated. And the next strategy would be either to use blocks or wedges. I personally, I'm fond of using blocks. I don't use bone graft in very big defects. I think because instantaneously you correct it and you get good results. And here, these are the example, large bone defects, and you can convert this defect into, if you're using the blocks, into a kind of a rectangle, and then use a metal augment or a block, and with a stem obviously, and the jigs are available to make precise cuts, and you can use this, and you have excellent and no change in post-operative regime, next day full weight bearing, and you can forget it, for 10, 15 years they're okay, unless you're unlucky. And these are examples of medial 5 millimeter, lateral 5 millimeter, 10 millimeter blocks, bilateral 10 millimeter blocks, and I mean, in my hands, they're done extremely well. Block is, problem is that creating block, you have to take a lot of bone, whereas if the wedge, you lose less bone, but I mean, blocks are more easily available, less, wedges are a little less easily available, and blocks are simpler to do. And similar strategies for the femoral defect, you can use blocks in that if required, or a bone graft if required, and same strategies applied. And the metal augment advantage is that, as I said, there are available blocks, and immediately you can use it, and you're on the table, you're sure. And disadvantage is they're expensive, stem is needed even in graft, and sometimes they can give problem, mostly they don't. And segmental defect in primary situation, one will hardly see unless there's a huge big fracture which happened. Sleeves and cones, one will hardly ever use in these situations in primary, but in very rare cases, as I said, in post-trauma or something, we might have to use it. So, since somebody don't go in classification T1, T2, F1, F2, just remember whether it is a defect which is contained or uncontained, whether it is a small one or a big one. Can I use only cement? Can I use cement and screw? Can I use graft? Can I use morselized graft? Do I have to do a graft with a screw, or do I have to do a mesh and impact it? And with that I use a stem, or if I am used to using augments, use a block or a wedge and then do the full weight bearing from next day. So don't go by classification, just think what you have to do on table there, and then it's a simple. I won't even include it in a complex primary session, to be honest. Thank you for your attention.
Thank you very much for that. All the talks are finished. I think we'll invite all the panel members, Dr. Amresh, Dr. Vadva, and Dr. Tomar on screen, while Dr. Amresh is setting up this, the first case that he wants to present. Go ahead, sir. To be honest, I've been given a very lousy job of being a moderator. See, read it a monitor. So we're running out of time. I'm getting some glares from the downside. We'll stick to one case, and the case presenter can ask the questions. And sir, I think as all panelists, we will not give our philosophy. We will give what the plan is and what our solution is. If we disagree, then we can talk among ourselves. I think Dr. Amresh, without further ado.
Yeah. So thank you organizers for inviting me, and thank you Tuche for inviting me for the talk. So we're talking about a 57-year-old lady with no known comorbidity, severely advanced osteoarthritis of both the knees. Predominantly, it's a windpipe deformity. She was wheelchair ambulant when she came to us, and she was probably, there was a differential diagnosis of synovial chondromatosis in that case. Now, this is what the patient's still photograph looks like. So you can barely see she was absolutely non-ambulant and dependent on the attenders for making her walk even 2 steps. Plain X-ray showed a subluxated knee, medial defects, collateral ligament probably was not functional, and probably extremely severe synovial chondromatosis. To analyze for the defects, we had got a precautionary CT scan done. This is what the CT image looks like, the 3D reconstruction. MRI showed gave us a differential diagnosis of PVNS stroke synovial osteochondromatosis. So now how do you go about it? That's the first thing that comes to your mind, whether you want to do it, what sort of implant are you going to use, what's the surgery that you're going to use, and whether you want to do both the knees at the same setting.
So I think, can we have a raise of hands in among the panelists? Do we want any other investigations to be done? A yes or no? He has a, sir, it's all done, sir. There is no neurological here. He has a diagnosed case of synovial chondromatosis. Do we want to do anything else? No, I think Dr. Vadva, not. So we don't want any more investigations. We are doing a simultaneous or stage replacement. Is this a special case, or is this like a routine, whatever we do?
I think the years gone by when my hair were black, I would do one stage bilateral. Today I would do staged.
So the idea is that the decision
is grossly obese. Her BMI definitely is more than 40.
So
more than 40, I would not do
the
bilateral.
synovial chondromatosis does not make a difference here.
No.
It does not make anything. Choice of implant, as usual, we would like to keep a constraint here.
Yeah, obviously, constraint has
So
to be
we have to have a constraint here. We go ahead, sir. We go ahead. Do we need a CT scan of this patient? Does it give us any idea that we did not have earlier with the X-rays? Would we prefer a long leg?
Scanogram.
Scanogram. Okay. Sir, now that you're presenting a CT scan, did you get any information out of this?
So scanogram was out of question. There were two reasons. The first honest confession is that it was not available.
See, what we don't have is don't have, sir. Don't worry.
Yeah.
One thing, you're the boss here today.
So first honest confession is we don't have it in the hospital, and second one was that she was barely able to stand. So it was probably not possible for me to.
Some people are not able to stand.
One thing, Simon, I think frequently overlooked, we must have X-rays of the pelvis, and if in doubt, we must rule out stress fractures of the neck of the femur. They're very frequent in such patients who have not been ambulatory for a long time, and if they go overlooked, then everything is in a soup.
I think that what we want to assess is don't forget the basics. Look around the knee joint also. We'll go ahead, sir.
So we did get an X-ray of the LS spine, which also did pick up the pelvis, but then clinically there was no indication for me to, at that point of time, to think about the pelvis because the hip joint was absolutely pain-free and fully mobile. So now, as far as the CT was concerned, I didn't want to be caught up by a surprise. It's easily available with us. I basically wanted to see what sort of defect are we predominantly dealing with, because X-rays only gives you two-dimensional. I wanted to see the whole thing now. So basically, we wanted to rule out infection. I think all of us would want to do that. So we got the basic parameters done. And now we come down to the operative planning stage.
With this ESR 53, did you do an aspiration, sir?
We did. It was normal.
That's great.
Now, what next? Do we still go by what Dr. Hemant had said? Do a single stage procedure or do it in both cases?
I think let's not debate onto a single stage versus a stage. It's more of a philosophy, as Hemant has already set out. So
I can give you my take on this.
So I would, my parameters, if the ASA grades and other parameters okay at 57, should consider single stage bilateral as the first step. But again, not to debate around that part. Regarding the choice of the implant, again, the philosophy used in, many times I can still circumvent with a CR knee in these cases, right? So CR to a PS to a constraint, everything available on the table. Along with that, you need to have the tibial bone extenders, because many times the bone sediment that you get across is very, very osteoporotic, I would say, not supporting even the screws that you want to put in as a hold, as an anchor, really don't work in these cases. So a must to have a tibial extender available with you on the table. What you also need to do is very thorough and very extensive synovectomy. So in those cases, doing a good hemostasis is also extremely important, because these are patients who develop a lot of hematomas post-surgery. Apart from that, the same standard protocols of DVT and infection control.
So my rationale for, we did both the knees at the same time. So one of the rationales, Dr. Evans sir, was that by doing one knee in this patient, I would still not be able to make her mobile. We would still reach where we had started from. That was number one. And number two, she was in ASA1. And then I had the courage at that point of time to, once I did the first knee, I had my options open if at all the surgery got prolonged, or if at all we fell short of some amount of instrumentation or implant choices that we wanted. So then we would have kept it staged. But predominantly we went ahead with the plan of doing it in a single
Actually, that's the beauty of a knee replacement. When you think it's actually getting complicated, you increase the constraints. So usually surgical time does not go high. So we'll go ahead, sir. We'll go ahead. We had, these are the backup that you had in your.
So this is what was used. This is what was used for the.
This was used for this.
Yeah, we did the right knee first. This is the choice. This was the spectrum of implants which were chosen for the right side. That was the spectrum of implants which was chosen on the left side. No real reason choosing between RHK and S-Storm. Just happened that way. We kept taking intraoperative images.
I think one question I would like to ask the panelists all here is that you have a backup, no doubt on that, but would you try to use a hinge first of all? I have no question, I have no doubts on what you have done. I'm just asking the thought process. In this deformed knee, would you bang in as you incise? Would you try to go in for a hinge, or you actually try to do a non-constraint? Does not go, then you go to constraint.
Yeah, I would have thought that it's a sequential process during the surgery. I would in fact start with PS knee to start with in this particular patient. I know obviously with stem extension because of the defects. But if PS, you think that soft tissues are not good, I would extend to,
So we go sequentially.
RST would be the last option.
We keep our minds open, and if it doesn't work, we have a constraint. Dr. Tomar, or anybody wants to make a comment on this?
I think the same view. We should start from the PS knee and then maybe semi-constant, and this is the last resort. Because if we have to go for this hinge prosthesis, then we have to be sure from the first end that there was some kind of gross ligament instability.
Dr. Tomar, if you come on, then we have your case also now,
So
because we're running out of time.
if you go back to the first image where I showed the patient standing and the video, it left no doubt in my mind that the ligaments was absolutely non-functional. Of course, clinical examination also did reveal, and that's what made me jump to the conclusion of you going in for the constraint implants in the very first place.
I think that's a great plan, sir, and we all need to have a backup. We are running short of time. I think Dr. Tomar,
I just have a question.
Sir.
Now it's a wind strap. There was one side which was a varus. Did it really require a rotating hinge for a varus knee also?
Yes, sir.
You see, when there are
I
large
think
bone
we'll load the
defects,
next case.
when you are examining clinically with large bone defects, you may feel that the ligament is not functional, but actually that is because there is big bone defect. So one has to differentiate.
Yeah, many a times what feels like a huge defect, in fact the soft tissue sleeve and the medial collateral sleeve is actually pretty good, and you can actually work around, but it depends on the case-to-case basis.
I think while this setup is being done, I like to make one note that, see, all the new guys, when you see a grotesque knee, we are scared. The grotesque knees are actually easier to do, easier to balance. We just have to take care of the bone defect. It is actually the simpler knees which are actually going to give you trouble, which you'll see as you practice. I think without further ado, Dr. Tomar.
Yeah, good afternoon, everyone. And I'm grateful to Dr. Ramnik Mahajan and his team for giving me this opportunity. This case is a conversion to TK from a failed STO. It is not moving forward. Oh, yeah. So this is 65 years old obese female. The weight is around 90 kgs, so obviously obese. And there is progressive bilateral knee arthritis for last 6 years. Bilateral knee osteotomy was done 6 years ago. Range of movements was 10 to 80 degrees of flexion. Obviously, the varus deformities in both the knees, and the gait was antalgic. So this was the video. At the time of presentation, she is obviously obese lady, and it is very painful knees. So this is the X-ray of the right knee, where in this case the open wedge medial osteotomy was done, and it failed into the varus deformity. The other knee was, the left knee was closed wedge lateral osteotomy was done. It also failed into varus deformity. And here you can see the various slopes and the bone deformities. So dilemma and option of the treatment are, so the main concern in this is closed wedge high tibial osteotomy distalizes the joint line, thus increasing the patellar height. While, however, patellar height is increased, but it leads to patella baha only because of the fibrous tissue formation, and open wedge high tibial osteotomy presents with patella baja also. Medial open wedge high tibial osteotomy, in medial wedge there is a posterior slope, whereas in the closed wedge osteotomy there is an anterior slope, because we don't have any control over this. High risk of complications and revision due to aseptic loosening, infection, stiffness, and patellar instability are always there in these cases, and outcomes are unclear. Should we proceed with the previous exposure? The skin incisions, skin incision of course is not shown in this, is a concern, has already been discussed. The consider removal of hardware in single stage or in 2 stages, or the 2 stages replacement. First we remove the implant, or we remove the implant in a single stage. So what is the opinion of the house? Whether single stage or unilateral or bilateral, single stage or 2 stage osteotomy replacement?
Any
This
kind
has-
of implant to be
yeah,
used?
This has been just now elaborated very nicely by Dr. Okankar, and most of the time we do in a single stage, as only one surgery. If possible, we incorporate the same incision, or go with a standard plan of planning the incision with at least a few centimeters of the gap between the two incisions. The lateral most scar is, if possible, we'll use. Implant removed, same stage, everything is done same stage. You are going to need a wedge and stem on the tibial side.
So I think, as you rightly said, starting from top to bottom, mostly a single stage conversion bilateral in these cases. Now, tackling with patella baha, one of the tricks that we all do is use a patellar component that is one size smaller and use it in a bit of a superior presentation over there. So that's the only way you can circumvent it. Your plastic is not going to be hitting onto the this one. Patella is not going to be sitting on the insert. So that's the way you position your patellar components in these cases. Rest, depending on the case, you normally would sail on like a normal presentation. The choice of the implant also, again, the philosophy from a CR to a PS, whatever you feel like, can work in. The only point if you're doing a CR is working onto the posterior slope. Because depending on whether you have a medial opening wedge or a lateral closing wedge, your tibial slopes, the natural slopes are not there. So you have to be very particular when you are going to fix on the slope in these cases if you are using a CR knee.
Yeah. So stage all these concerns have already been discussed. So this was the post-op X-rays. The single stage and the bilateral knee was done using the stamp, and patella was also replaced in these cases. This was the left knee. So right knee where plate was there and the plate was there, so I preferred using the stamp. But on the left knee where only the staples were there, I used one without stamp. And these were the patient was able to walk the next day of surgery, and these were the kind of movements by the end of 4 weeks. So she was comfortable, and there was good range of movements to about 130 degrees of flexion.
We conclude here, sir?
Yeah. So the correction of deformity, the lower amount of tibial bone resection, we try to minimize the minimum bone from the tibial side and try to raise the joint line to normally with a sufficient polyethylene thickness. Stamps are sometimes used, and patella should be replaced in almost all the cases, because patella baha problem is always there to have a good range of movements. Thank you very much.
I think this session comes to an end here. We'll not stop you between for lunch. I think we'll have a formal presentation round.
Yeah. So we'll have just a small memento distribution. May I call upon Dr. Simon Thomas and Dr. Narayan Hulsep, please. Dr. Vivek Logani. Dr. Vivek Logani.
Are you here?
Yeah. Guys, just listen. We are serving the lunch, but we have a live Mako TKR starting right at 2 o'clock. So please be on time. Dr. Simon Thomas. Dr. Hemant, you can stay here. So we can, may I call upon Dr. Lalit Maini upon the dais, please. Dr. Lalit. Dr. Lalit Maini. All right, we can start. He'll join us later.
Right, I'm the first speaker in this session, and it's actually the extension of my first talk that was on post-osteotomy TKRs. Here I'm talking about TKR in extra-articular deformities, so I'm obviously not going to talk on tibial HTO deformities anymore. We all appreciate that these are extremely complex and very uncommon, and there are no clear guidelines in literature here. Every deformity, every single deformity does require a great deal of analysis and planning. These are usually previous osteotomies or malunited fractures, but occasionally you may have metabolic bone diseases or congenital bowing or even Paget's disease. So these are obviously the etiologies for extra-articular deformities. I'm just going, next 8 minutes, I'm just going to elaborate on the principles and just establish some principles with some cases. Now the deformities are going to be in any of the three planes. In the coronal plane, it will be varus valgus. In the transverse plane, it will be torsional, and it will be flexural and extension deformities. Most of the deformities, especially malunited fractures, could be triplanar. Now any intra-articular torsional correction is obviously difficult. If you are going to try and correct the torsional deformity, it is going to be difficult. If a femoral deformity that you try to correct intra-articularly, you end up having flexion imbalance, and as a consequence could have patellar maltracking. Because as you understand that patellar tracking depends on the femoral rotation, and if you tweak the femoral rotation, you could have trouble on that grounds. So any significant femoral torsional deformity or torsional malunion would require a corrective osteotomy at the malunion site. Similarly, on the tibial torsion, here is a patient who has had a malunited tibial fracture, and you can see the intowing. The tibia is united into intorsion. And if you try to correct this with an intra-articular tweaking by internal rotation of the tibial component, you can end up having patellar maltracking again. So this is a problem with torsional deformity correction. So it's going to be difficult if you try to correct it with intra-articular measures. So this is the one significant principle that one needs to understand, that torsional deformity is difficult to manage with TKR alone without an osteotomy. Now the question is, how are you going to deal with this deformity? The option is two-stage, where you do a corrective osteotomy first, fix the osteotomy, allow it to unite, and then TKA. But as an arthroplasty surgeon, I think one is interested with doing a TKR with intra-articular correction or TKR with an extra-articular osteotomy combined at the same time with TKR. Now, intra-articular correction, whether it is possible or not, depends on the magnitude of the deformity, distance of the deformity from the knee, and obviously the location of the epicondyles. That's going to limit the extra resection intra-articularly. Now, here's an example of 20 degrees valgus malunion. Now, on the extreme left, you can see 20 degrees valgus malunion at proximal femur level. And as you go to the right of the picture, the malunion is nearer the knee. What is shown here is the long axis. If you look at the extreme right of the picture, this is the long axis, the mechanical axis of the femur, and the femoral cut being perpendicular. We're talking about mechanical alignment here. Femoral cut being perpendicular, it ends up cutting extra bone on the medial side, on the femoral side. So this is what intra-articular extra over resection that is required to compensate for the malunion. And the distance of the deformity from the knee makes a big difference. On the extreme left of the picture, there is very little difference on the two bony resections in the medial lateral side. Extreme right, you can see the malunion is very close to the knee, and as a consequence, you have excessive medial resection, over resection of the medial femoral condyle. And same thing would happen on the tibial side. So what essentially happens in this scenario is that because you are resecting extra bone from the distal medial femoral condyle, you have secondary instability that is created. And that secondary instability is in extension only. Your medial collateral, as a consequence, becomes lax in extension. So secondary imbalances that are created by the intra-articular correction is a problem, and that needs to be tackled. Now, extent of the over-resection is also depends on or limited by the location of the medial and lateral epicondyles. And obviously, any extra resection above these levels, you will be violating the collaterals, and that is a big no-no, or we'll have to go for a constrained option. So alternative alignment strategies are certainly useful here. But if you looked at robotics or all these modern technologies that allow you to be precise as to how much of varus, for example, as you saw, Mahesh accepted 3 degrees of varus. There are surgeons who accept 5 and 6 degrees of tibial varus as well. Similarly, on the femoral side, you could accept some degrees of this malalignment, and that is going to be beneficial in these scenarios as well. So use of technology becomes mandatory in these scenarios. Now, here's a patient that had come to me about 15 years back, and those were the heydays of navigations, and we are just starting using navigation. And mind you, without using navigation, these cases are practically, very difficult to manage. So this patient was managed using navigation. This is just showing you intraoperative pictures of the same. And this is the alignment that was achieved after using navigation. And that is the only way one could do this. Another patient who has a big implant on the lower half of the femur, and if the surgery was to be done without removing the implants, the only possibility was navigation. That is what was done in this case, and that is the post-operative X-ray of the same patient. Now, here is a patient that we did recently using Mako. Here is a patient who has a deformity almost in the mid-shaft of the femur. This is the old malunited fracture. And this is the first screen. You can see native deformity, native varus of 30 degrees. And as you can see in the implant planning, there is very little bone being taken off on the medial side. And this is after doing the releases and the balancing. As you can see here, I'm getting 24 millimeters gaps here. Even the implant would be tweaked further. And important thing to appreciate is that very little bone is being taken off from the medial side, medial femoral condyle here. And that is just to show you the intraoperative picture of the same. There is very little bone is taken off from the medial side. And because of the bowing of the femur, the deformity of the femur, you can't really use a long intramedullary extension stems here. And obviously, this required complete medial side release and using a constrained implant. So that is basically what has been used here. And that is the postoperative X-ray of the same patient. So technology is mandatory to use in this patient, especially if you want to do an intra-articular correction only without touching the deformity per se. Here is a patient who has a significant femoral malunion. I think you can appreciate it is a triplanar malunion, and this cannot be managed by any intra-articular correction. And this has to be managed with osteotomy of the femur at the apex of the deformity. And that is the postoperative X-ray of the same patient. This progressed to union within a matter of 4 months. So the tibial side, I'm not going to talk about high tibial osteotomy, which I've done with the previous talk before lunch. So again, the same principle, the closer the deformity to the knee, the larger the problem it creates. And it does create secondary instability. I'm not going to talk about this topic I have dealt with before. Example of tibial malunion required a closed wedge osteotomy, a wedge being taken off, wedge closed, and a stem used, and this progressed to union in a matter of 3 months. Another patient who has a malunited fracture, it's not possible to do an intra-articular correction, as you can see on the long film. So osteotomy done, osteotomy closed. Just checking on the II that I'm getting a good fit in the medullary canal, and that is a post-operative X-ray, and that is a union after about 3 to 4 months. So again, here fracture very close to the ankle, very little influence on the knee per se. So you can get away with a normal implant, but the implant looks funny because the tibial implant is actually pointing towards the ankle that is gone laterally because of the malunion. So the difference between the femoral and tibial intra-articular correction is that compensatory distal femoral cut will produce instability in extension only, whereas compensatory proximal tibial cut will produce instability in both flexion and extension. Any deformity nearer the joint line greater than 20 degrees will need to be corrected with an osteotomy. So to summarize, need meticulous planning, femoral epicondyles restrict the compensatory resections. They do produce a ligamentous imbalance that needs to be corrected, and larger deformities would require corrective osteotomy. Thank you for your attention.
Thank you. Fantastic. Next talk is by Dr. Vijay Kumar on constraints but non-hinged in ligament insufficiency. A couple of points about these extra-articular deformities is, if the deformity is in tibia, I think it is a little easier than the femur to correct. And also, if the deformities are nearer the joint, they are more difficult. And especially if the deformities are farther, maybe easier.
Yeah, because even if you want to do an osteotomy, and correct the deformity, having the deformity closer to the joint, means that you can actually use an intermedullary stem and bridge it. A deformity coming to the middle third of the tibia, you can't bridge it with a long stem because no stem is going to span it accordingly. So you will have to fix it with a plate if you are doing an osteotomy. So
And-
that complicates the whole thing.
And these technologies can also help if you are going to do a combined osteotomy, if you put the pin disturb.
Yeah.
Okay. Okay, good afternoon to everybody. Well, I'm going to speak on constraints, but not hinge in primary TKR. Well, now, post-infection, I think instability is one of the biggest cause of revision. This was Australian registry showed. So, if you are having some problem getting your knee balanced and the alignment is not good, I think constraint is something which you should have on table. What is constraint is basically a mechanical substitution for the normal stabilizing function of the soft tissue, specifically used in complex situations where you're not able to balance the knee, or there is varus valgus instability, or there is a flexion instability. And the constraint, there's a continuum of constraint. It starts from a CR knee and goes till the hinge knee, right? So you have various, the CR or the AS and the PS are the standard knees that we do. If you want a little more constraint, you can add to something called as a PS plus or a mid-level of constraint. Then you have the CCK sort of constraint, and then you have the the ultimate constraint, which is a hinge, a rotating hinge, or a normal hinge. And as you go up in the ladder of constraint, the problem is that you start putting a lot of stresses on the fixation, and then this would result in increased forces at the interfaces, resulting in increased chance of loosening and breakage. So the dictum is always to use as little constraint as possible. And the design principle for the newer semi-constrained implants are that they have a wider post which engages with the box, and it helps in the varus valgus constraint as well as the rotation. Some of these designs you need to change the femur. Some of them now have the same femur you can put in a PS plus sort of constraint, right? But you should know these. So these are all different sort of constraints. The Merrill has PCK, then you have LCCK, you have TS plus, you have TC3, and all of them, and the Legion also has from Smith Nephew has a little more constraint poly. But you should know how much is the internal external constraint that is possible with it, and the varus valgus constraint. So every knee is the constraint knee is different. The indication is basically most commonly it's used for a valgus deformity, a severe valgus with an incompetent MCL, or a severe varus with a overstayed LCL. Sometimes in patients who have got bone defect, or there is a or persistent laxity, or if you have a severe flexion contracture, you are unable to balance the knee, especially the flexion extension imbalance. All right. So this was an article in which they described that you should definitely use a semi-constrained sort of implant if you are not if your opening is more than 3 mm. At least at 0 and 30 degrees, and what they found was whenever the deformity was more than 20 degrees, there was a high chance of using a constraint. Some of the examples is a wind deformity on the right side, a severe varus with almost a subluxated knee, and the left side was a valgus in which a constrained implant was semi-constrained implant was used on the right side, but we could get away with a normal implant on the left side. Another severe varus with some sort of subluxation, again a Legion constrained implant, another similar. So these are X-rays that you would find in your practice, and it's better to have a constrained implant at your at your table so as to bail you out, a semi-constrained sort of implant. And this was a flexion varus. Another one, a stiff flexion valgus knee. Here again, you might require a constrained implant, a severe valgus in which the bone was osteoporotic, so a stem was used on both sides. Another one, a SCCK sort of constraint has been used. And a stress fracture along with the extra-articular deformity in which a long stem along with a constrained implant was, semi-constrained implant was used. What are the results like? The results are, what it has been shown that, most, there are plethora of papers which say that the CCK type of implant, they work good for around 5 to 7 years, even till around 8 or 9 years. So, so this was a systematic review and a meta-analysis which has just come in 2019. They had more than 3,620 knees, and then they found that these offer a very significant clinical improvement with no early failure. However, you need to be careful. The failure starts in the second decade. So the cutoff point is around 7 years. After 7 years, there is some sort of acceleration in the rate of revision. So as high as 28% at 20 years. What about the mid-level constraint? That is the the PS plus type, or the something like Legion plus. and PCK type. So these are a good substitute to the TCC or pure LCCK, and these are a lot of studies which have shown that you can achieve stability in these knees. And now with these knees, many people don't even put stems. So they are going away from putting the stem because it has its own complication with risk to embolism and increasing operating time, cost, and other things. However, if your metaphysis is weak, or if you are having osteoporotic patient, it's wiser to put a stem in these patients if you're using a semi-constrained implant. And this has been seen in literature also. So you have now a lot of articles, these are all recent articles in which they have used a CCK sort of knee or a mid-level constrained knee without a stem, and they found no increase in aseptic loosening or revision, and have said it to be safe to use. Another of these systematic reviews, another one which was quite recent, in which they found that whether you use a stemmed implant or stemless implant, the chance of revision and aseptic loosening is slightly more in a stemless implant. And specifically with the Indian situation, you should be careful with using these constrained implant with a stem on the female side. This was a report in Arthroplasty Today in 2022, in which they have 5 patients of primary TK in which they use a semi-constrained sort of, that's the CPS, the personas, mid-level constraint without a stem extension, and these patients had a fracture on the female side, and the thing that they noticed were all were female, all had a valgus deformity, all had flexion contractures. So if you are using a semi-constrained type of implant, it's better to put a stem femoral component if you are using in in an elderly female patients who have got specifically a valgus deformity and have osteoporosis. Right? But there are limits of this constraint also. So this was given by Barak long back in 2000, that if your flexion extension gap imbalance is more than 5 to 10 mm, if you're not able to restore your joint line within 10 mm, or if you do not have any collateral at all. So so here you require a hinge. So if you require some sort of collateral in order for this to work. If the MCL is absent, then definitely you can't use a varus valgus constraint sort or CCK sort of implant, but you need a hinge. As was in this case, this patient had a injury of the MCL with the ACL, was not treated, and came and was with arthritic knee, and hinge was done. So constraint is basically a fine balancing act. So if you increase the constraint, there is a chance of increased wear and loosening. However, if you decrease the constraint, there will be increased instability, and these needs would fail subsequently. So the conclusion would be try to use the least amount of constraint, and always have some sort of semi-constrained implant if you're using complex knees. Right, so in the end, I would like to invite all of you. This is our annual AIMS Arthroplasty conference that we have every year. This year it's around on 1st to 3rd December. We have live surgery panel discussions, and we also have abstract submission for and with prizes also for if postgraduate students and senior residents are interested. We have 2 cadaver workshops, one on complex primary and revision total hip replacement, and another, I don't know, I'm not aware if there's any on unicompartment knee replacement cadaver workshop, so we are having it for the first time. We have around 7 international faculty confirmed as of now, and we will be having all the 5 robotic systems available in India in a hall, and you can have a hands-on experience on all these 5 robotic systems. In addition to this, we have around 11 live surgeries as of now confirmed, out of which 5 are robotic. One is technology assisted, and all other 4 are all conventional surgery, revision, TKR, and direct anterior, and a UKR. So I would like to thank you, and like to invite all of you to our meeting this year on 1st to 3rd December. Thank you very much.
Thank you, Dr. Vijay Kumar. May I now invite Dr. Gurwar Reddy. He's going to tell us about his experience using robotics in complex situations.
Good afternoon, everyone. I think I was instructed by the organizing committee to fill in Maria's talk also, because Maria has got a non-robotic situations. So I'm just dwelling on that, and then I'll go to the robotics. Okay, no, just now. I got 15 minutes, luxury. Yeah, don't start the slides now. Yeah, I think majority of you youngsters are the main target group for any conference. And I know that the objective of any conference is to confuse you at a higher level. That's what we all intend to do. How many of you have got robots at your disposal? Lift your hands. Okay. Yeah. Hardly a handful of people. So I'm targeting the next 5 minutes, not these slides, for the people who are there. The complex situations, basically varus, valgus, flexion deformity, recurvatum. Those are the complex situations. Extraarticular deformity, already Hemant alluded to that. And first of all, when you got a complex deformity, don't get intimidated by that. That is the principle number one. Number two, a lot of the speakers in conferences keep on saying the learning curve is so big, so down, all that stuff, giving you a subtle hint that they are the only guys to do and you are not the guys to do. Absolute bullshit. Whatever I can do, you can do. Hands closed. In 100 surgeons, only 10 surgeons are gifted, like a god sculptors, and 10 surgeons are butchers. 80 of us are above average good surgeons. If you know the basic principles right, you can get the things right. So that is principle number two. Don't believe in the speaker saying that they can do or you can't do. Number three, when you have a complex deformities, first of all, have another colleague of your wavelength to come and assist you. That is a fundamental principle I keep on telling you. Have another guy, a friend of yours, come and assist you. Number four, see that the inventory is always available. So a lot of the time, when you are young, the companies won't quote you. They quote people like Manoj and bigger guys. They will be there outside his clinic, but they won't come to you. They will say, sir, everything is available. When you open the inventory, some of them are missing. So please see one day before all the inventory is available. Because this is, sorry, there are company people also there, it seems, but that is a bitter truth. Okay, so see that all the inventory is good. And number four, select the implant which you are going to use mentally and conceptually beforehand. So when you got a complex deformities, the best way is to go for a posterior stabilizing knee. Or if you are a cruciate retaining man, you select an implant with a backup of deep dish. So just don't go with a simple cruciate retaining implant. Sometimes it is difficult if you got a cross deformities. And second thing is the varus deformities, however grotesque they look on the x-rays and clinically, the moment you anesthetize them, 80% of them come into the regular manageable things. So don't be intimidated by that. The worst thing or the most difficult thing in the deformities is the recurvatum knee. So recurvatum knee, till today there is no answer. Even the hinges don't work well. So be careful about the recurvatum knee. And again, whenever you're doing a complex deformity knee, the worst thing you can do to the patient and yourself is having a recurvatum knee on the table. That's why I told all the 10 principles or 10 things to do. One thing is never to get a recurvatum knee. That's one of the important point. And third thing is always have a backup. Just now Vijay Kumar has told you about the constraint backup. You don't need to go up to hinge, but 90% of the time you can get on with your simple PS knee, but TC3 or varus valgus constraint knee, backup is a very good solution for that. So without that backup, never go there. Because sometimes the deformities are so bad and sometimes your technical fallacies will jump the flexion and extension gaps. The only bailout is a varus valgus constraint knee. So that is another principle. And now coming to this soft tissue releases and all that stuff, you have seen that brilliantly in all the things. Put it in a figure of 4 and then see the posterior medial side and then keep it under revision and do that gradually. And don't get worried even flexion deformities. Popliteal artery, even if you wanted to do your mother-in-law's popliteal artery damage, it won't happen. Because very, very seldom, unless your stars are very bad, you won't kill the popliteal artery or you won't cut the popliteal artery. Because God knows that we are all stupids. That's why He has kept popliteal artery very away from this. Very few times you will damage the popliteal artery. But be careful, obviously simple principles are there. So these are some of the basic principles in dealing with complex deformities. As implant selection, soft tissue dissection, and flexion deformity also, you can go right up to the 40 degrees. Again, with the laminar spreaders are very important instruments. Under the vision, you can do the capsulectomy. No need to worry at all. Until the soft tissue from the back of the capsule sees you, you can do the capsulectomy. And there are, again, very standard methods are there. And again, don't get intimidated by the complex deformities. You don't need a robot to help you out. So these are some of the things from non-robotic interventions. Now let me go to the robotic side. The slides, please. So basically this talk is, because like this morning I was telling, a lot of Western literature, Western surgeons deal with not more than 10 to 50 degrees of deformity. The moment they see our deformity, they don't get sleep on that night. So those people are now literally asking all these Western guys to do what is the validity of the robotics in the gross deformities. That's why our team has come up with enhanced mid-resection workflow. And so basically, the gross deformities, let us go to the definition of the gross deformity. And the definition of the gross deformity is very different from the Western and Indian literature. For Western people, varus or valgus more than just 7 degrees is gross. For us, that's very bread and butter. And this is a classification of the coronal deformities, and 0 to 3 degrees normal, 4 to 10 common deformity, 11 to 20 substantial, 20 to 30 important. I don't know what is important, not important. What is this classification? I don't understand that. And more than 30 extreme deformity. And we have done so far 5,000 procedures, more than 5,000 in the last 2 to 3 years with robotics. And you can see our deformities. 60% are substantial or important or extreme deformities in our practice. So is your practice also. So in other words, we are dealing 60% of the time with a gross deformities. That signal is for the first 8 minutes or second 8? All right, wonderful. And that signal is so big here. Okay, it looks like a fire alarm. So right, so basically when you come to the robotics, you all know that, Suhas already alluded to that, 2 workflows in Mako totally to achieve the pre-balance. The beauty of the robot, whenever you got one, is you can keep on thinking, planning, replanning, then only cut at the end. So if the gaps are balanced by just moving the position of the implants, different alignment strategies, functional alignment, target is 18 mm with 9 mm poly, all cuts are made simultaneously, and it is useful for simpler deformities less than 50 degrees. That is what we all do, like a pre-resection. Now coming to the mid-resection workflow, that means pre-balance after 2 cuts. This is called mid-resection workflow. Then there is another thing called enhanced mid-resection. The mid-resection, the pre-balance are not achieved even after functional positioning of the implants. That means Mahesh, you have seen, Mahesh played with a lot of the implant positioning, but still he is unable to get the numbers right. So then he has to go to the next line. And if the cut distal femur and proximal tibia, you do that, and you see the balance of the extension gap, and then you capture flexion gap, and then you execute the rest of the cuts. This is called mid-resection workflow. So endpoint of the dynamic joint balancing, you can see the difference between the robotic and manual. Robotic plan, assess, balance, and cut, whereas here in manual it's different. So now let us see mid-resection workflow. It did not achieve the pre-balance in all. So again, exactly that's what happened in the morning case. In most gross deformities, we could not achieve pre-balance even after the 2 cuts. That means the mid-resection also could not give that objective what we are aiming at. So then the main offending structures were basically why we could not do the mid-resection workflow, achieve our objective is the posterior osteophytes. Again, you have seen that big osteophyte and the tight posterior capsule. Now the challenge is how can we achieve balance in these severe deformities with large osteophytes? That is where we innovated enhanced mid-resection workflow. It's a classical example of Indian surgeons contributing to the global phenomenon. Now this is going to be the regular, the manual from Stryker coming into the picture. And all the Western surgeons are quoting this paper now, and they are doing this for the gross deformities. This is not a rocket science. We just simply put our mind to the thought, and then what else we can do. This is the paper which we published it. And what we exactly do is, after distal femur and proximal tibial cut, we go and do a provisional posterior medial femoral cut. And this is feasible because the robot has even sub-millimeters cut precision. The advantages are it gives access to the posterior medial osteophyte and capsules on the femur, and it helps balance the extension gap, and then you can assess better of flexion gap before coming to all the femoral cuts. So that is pre-balance after 3 cuts. So the provisional cut is important. So this again, as I said, we already published the paper. Now indications, the mid-resection, enhanced mid-resection workflow, extension gap not balanced after the tibia and distal femoral cuts, and even after removal of the tibial osteophytes with soft tissue release around the tibia. Due to severe posterior medial tightness, flexion gap assessment becomes difficult. Those are the indications. Now I'll take one indicated case here. You can see this initial deformity capture is 28 degrees of varus deformity. Yatindra was asking in the morning, why don't you release and then go to the bone cuts? But the objective of the robot is to minimize the bone cuts. So by principle or by concept, you got to exhaust your boundaries or you exhaust your limitations of the how far you can go with the manipulation of the bone cuts, then only you go and release the ligaments. You can see this case is 28 degrees varus. So now we have removed the osteophytes, mid-coronal and beyond femur, and there is a big osteophyte underneath the MCL, which you can see it here. Now the 28 became 90 degrees varus. Again, for all the youngsters also, even without robotic, these deformities will keep on getting corrected once you do the osteophytectomy and all these things. So now 28 became a 19. And now what we have done is we functionally positioned the implants in coronal plane. We put the tibia in 3 degrees varus, which may not be possible manual, and 1 degree varus in the femur, and we raised the tibia by 3 millimeters. By that step, we are not even cut. The 19 degrees varus now became 11 degrees varus. So from 29, without cutting the bone, we already got to 11 degrees varus. Now we go to the provisional cut. That is what we call posterior medial cut. We've taken the robot and we cut 4 millimeter instead of 8 millimeters. You can see that in the diatherm, it's marked there. So by doing that provisional cut, after removal of that posterior osteophytes and posterior capsule, we managed to do that after that cut because we got the access. Now the varus is reduced to 4 degrees. So we are not even gone to the cuts. So by just simply doing this osteophytectomy, now 28 degrees varus has come to 4 degrees. So as simple as that, and now extension gap is balanced, and now provisional cut allows flexion gap capture with knee tensioner, which you already seen in the morning's one, and then by external rotation of the femur to balance the flexion gap. This is again another beautiful advantage of the robot. You can external rotate the femur right up to 3 degrees. Sometimes you can even interrotate the femur without jeopardizing the patellofemoral tracking, which you cannot do manually. Because it's sacrosanct, you say that you can never interrotate the femur, but you can do it if you got a robot. Because that will tell you where to stop and where the patella is jumping from the trochlear groove. So now rest of the cuts are completed, and bingo, 20, 20, 20, 20, that is the end point of the robot. Okay, so that is the way you do that. Now there are some examples here. This is the post-operative X-rays, and you can tell again and again, you can get that one. Again, some more varus deformities. And another beauty of the robot is, before going into that, you know how much bone deficiency is there and how to fill up that, you can plan that. That is a very important thing there. And again, another example, post-op clinical status, and varus knees galore. So again, you can see, in fact, you can see that the tibia is so subluxed, so no problem. And shape matching is so good in robotics. The posterior corner offset is restored, which is very well taken care. Again, another varus knee. And now we got one valgus with hyperextension. And again, you can see that 47-year-old male, the recurvatum and gross valgus deformity. And again, post-anesthetic induction assessment. Again, valgus don't get intimidated as far as it is correctable. Only the difficult part is the recurvatum and the non-correctable valgus knee. Correctable valgus is as good as a straightforward knee. So deformity assessment, you can see 20 degrees valgus, 20 degrees hyperextension. And again, component planning, thank you. For valgus knee, we can see here, tibial cut reduced by 5 millimeters, distal cut reduced by 1 millimeter, and femoral rotation parallel to almost 0 degrees to external rotation. And initial gaps assessment is done. And only 1 millimeter cut from the lateral distal femur, and only 2 millimeter cut from the medial tibial plateau. You can see how small we are cutting from the medial tibial plateau. And robotic arm gives us the ability to cut minimal bone in the recurvatum. So end result, with precision minimal bone cuts, we could achieve well-balanced knee 19, 19, 19, 19. So those are the things. And that is the post-op X-ray, and that is the 10th post-op day status. So role of robotics in complex gross varus more than 30 degrees, gross valgus with hyperextension, severe fixed valgus deformities, deformities associated with large bone defects, severe to super obese, difficulty of conventional jig placement is avoided, and extraarticular deformities, post-HTO insert implants. All of them are amenable for robotics, and I am not telling you the robot is the only way to do it, but that is one of the best ways to do it, and robotics is definitely adding a lot of value to our practice, which I can tell very, very categorically. I keep telling, when you go for a technology, there are 6 phases or 5 phases. The first one is called audacious. That means people bloody say he is a bloody idiot to take this one. That is audacious phase. The second one is apologetic phase. That means you do it, but with a bit of apology. Okay, you can do that, but I am doing this like that. The third phase is called assertive phase. The robotics have come to that phase as far as I am concerned now. The fourth one is advocative phase. I don't think I have come to that stage, or robotics have come to that stage. And the fifth is apostolic stage. That means this is the only way to do it. I don't think robots will never get that status, but in the global scenario, the robotics have come to the assertive stage now. Probably in future, it becomes as common and as affordable as an image intensifier. But don't get it wrong that robotic is the God's gift to orthopedics. No. It is your common sense and it is your learning of the basic principles. But let me tell you, friends, I resisted marrying robot for 5 years. 5 years I resisted. But then I got to say yes to that. But again, a lot of people, Bharat Modi is not here, isn't it? Okay? So a lot of people keep on saying, fighting to the end of their death, end of their life, saying robotic is only a marketing tool. I concede to some extent it is a halo effect. I won't say it's a primarily marketing effect, it is a halo effect. But end of the day, it has got value and it has got a tremendous impetus for your practice. Thank you so much.
Thank you, Guruva, for your wonderful insights into the robotics. Do you do everything in life with robotics? No, let's not answer that. Right, let me call upon Manuj, Dr. Manuj Wadhwa. He's going the US way. He's a man from US and going daycare surgery.
So good afternoon, gentlemen. Over the next couple of minutes, I'm going to sail you through the universe of rapid recovery after surgery or enhanced recovery after surgery. Now, there has been a paradigm shift happening in TKs from an inpatient to an outpatient TKs. So is the slide moving? Yeah. So pain can ruin your charm of surgery. So to be honest, Guru is sitting here, whether you use a robotic or use any particular technology, patient doesn't care. What patient cares is how comfortable the patient was post-surgery. So what you have to control is basically that experience factor, that control of pain. So whenever we give a surgical trauma, there is a neurogenic pain, there is inflammatory pain. You have to use analgesics, inflammatories, and a lot of perioperative care pathways so that their experience is comfortable and they can go back home the same evening. So this surgery is no rocket science. Your patients are the same. Your prosthesis is the same. What differs is you and your medical team. So it's basically an SOP, a protocol, the right kind of patient being chosen up and the right kind of criteria. So you have to think it the right way. It is a multimodal control. They require a lot of multidisciplinary teams to make it happen. You require a big team force. You require, apart from you, a good physiotherapy, home care teams, home nursing teams, your coordinating department, your anesthetists, porters. So all of them have to work in cohesion to make sure that you give an experience to your patients. So it is not the surgery or anesthesia, it's the ambulatory is the stay of the patient. What you want is the patient goes back home, sleeps, and his caregivers are very, very comfortable. So how you make it happen? So you have to break down the previous traditions. Couple of things that have to be stopped up. The first and the foremost, we apply in a lot of our surgeries. Dr. Ranawat trained us a big way on LIA, the cocktails, local infiltrative anesthesia. So no morphine or those products. You don't want the patients to, in the evening, to have the nausea, vomiting, or pruritus happening through. There is more preference. I'm not just saying the preference because a couple of guys use GA. There is more amount of a preference for short spinal anesthesia, early wean off rect, walking 3 hours after surgery. Get off the urinary catheters, no drains, and get off the tourniquets also. So these reduced social trauma surgeries are mostly without tourniquets and hypotensive anesthesia. Compression stockings, faster mobilization criteria, and you have to change your discharge criteria also. You have to think your surgery as if it's a snake bite. What do you do in that? You do apply cryotherapy, pain treatment, you give adrenaline compression bandages, the same kind of treatment, use of the right kind of cocktails, the right kind of mixtures. We have over the last 10 years formulated and transitioned to a lot of cocktail parameters in the beginning across, and we have been amending and modify. There is a technique for compression techniques also. So the mainstay that we continue in our cases is ropivacaine, 150 milligram in the initial, 2 milligram per ml, plus minus adrenaline, because adrenaline is not to be used in subcutaneous tissues. You have to understand very clearly on different studies where are the nociceptive receptors, because your drugs have to stop those receptors. Where are they? In the gutters, in the osteotendinous junctions, in the ACL, PCL, capsule, posterior capsule, synovium. So those are the places where your infiltration has to go. When you talk of subcutaneous tissues, please do not use adrenaline in those cases. A couple of those things you will find those necrosis coming up otherwise because of the vasoconstriction. So the cocktails that we use across is ropivacaine 300 milligrams with dexamethasone 0.3 milligram per kg, around 4 milligram is a good dose, with adrenaline 0.5 milligram. We always place an intra-arterial catheter. I'll show you in a small video. And the patient goes back home on an elastomeric pump with ropivacaine going at 8 ml per hour for the next 2 days. So the procedure is the same as you normally handle. It is just without a tourniquet and a simple parameter, no drains, no suctions, no catheters. So these are the systems. You have like an epidural needle, a long needle with you. You have antibacterial filters. Once you have made your block, you have given CN, you've done an arthrotomy, you use a ring block along the femur. So all throughout, you give a ring block. So once you have made your cuts, you will infiltrate in the posterior capsule and the medial on the lateral side. Once you're through with your surgery, you'll put up a catheter from the medial to the lateral gutter. Through this needle, you'll put up your catheter. Connect it through. You have to have around 20 centimeters of different markers in these tips. You put an antibacterial filter. Check on that your catheter is not kinked, you have fluid going through, and that's it. You put it in the lateral gutter because you have to make the patient mobilized. So it's put in the lateral compartment. So when the articulation is closed, you put in the last 30 ml, and this is where your Trenexa also gets in. We use local infiltration of tranexamine. Also, we use it at the time of induction, 3 hours and 6 hours after surgery. This is a elastomeric pump where you put in around 400 ml of ropivacaine, going in your patient at around 8 ml per hour. For a couple of those bilateral cases that we are trying to experiment on, we're using half the doses, 4 for each side, because we can't use 8 on each side, and trying to see an effect. It's a small database initially we're working on. So you use these pumps. The idea is you have to use cocktails to control the pain. You should not give the patient any breakthrough pain. So basically, the nociceptors have to be blocked. You don't want the pain stimuli to be going across to the CNS or the brain. And no use of any morphines or pregabalins or gabapentines. So this is fixed around on the medial side, then you have a catheter, and to which your elastomeric pump is attached. 8 ml per hour is going on. We have done different studies to book in all these PCAs with morphine to an epidural catheters to triple nerve blocks and femoral blocks to IPAC blocks. I think if you have not reached back, that this gives one of the best endpoints to our patients. So the care principles are very clear. You have to identify the barriers, leave useless traditions, but kill no good traditions. Your technique should remain in. Basically, what you have to give to the patient is a reduced tissue trauma surgery. First, get your principles right and then get on to a fast track. We have reached on to parameters where our incident till implantation is less than 10 minutes, but again, speed is not the, fast track is not the thing, first thing to be involved. First thing is follow the protocols right. Your discharge criteria has to be very, very stringent. Your patient should be able to walk a few steps, and before I sell on, this is not a surgery for every patient. You have to select your patient the right way. The right kind of ASA grade 1 and 2. Your anesthetics has to be very clear that the patient does not have severe comorbidities. Patient walks a few steps, take a light meal. All these patients are fasting for 6 hours, but fluids can be taken in the last 2 hours because gastric happening happens within 1.5 hours. There should be no wound leakage. Bending around 70 degrees, the patient has gone to the toilet, and you have to give them a proper control. So the patient screening is a foreplay. You have to have in good selected patients. You don't want to have complications. The patient has an MI when he gets back home. So anesthesia screening has to be extremely prudent because those cases, short spinal anesthesia is the preferred one. Very early mobilization within 3 hours. The patients are walking by the evening, and your care principles and protocols have to be kept on. Cocktails have to be used, reduced tissue trauma surgeries, no tourniquet, use of compression stockings, no drains, Trenexa to be used on a very short stay STU with an early mobilization. Equally at the same time, the patient has to be given up all those emergency contact numbers so that if they have something important to go through, at least their care is not compromised. This is where you can have your patients walking like this in the same evening before they're going back home. So it's one of the paradigm to be kept across in your practice for select subgroup of patients. Thank you.
Right, I think we can have quick questions if there are any from the floor before we go to the interesting case discussions.
Can I ask a
Yeah,
question
sure,
to
please.
Manoj? Manoj, how many times this catheter got kinked and the flow has not gone into the joint?
So it almost never happens once you put in the lateral compartment on the side. You loop around the superior part of the trochlea. That's why I enter from the medial side. Vastus medialis, you perfect through, go around the superior part of the trochlea and enter into the lateral gutter. It never gets blocked.
Really?
And because we don't use drains and all, because once you use drains, the thick drains that use the problem, the suture will get in. Here there is no way that you will tie it on your suture.
And how long will you continue the...
2 days. So basically 400 ml goes in, it goes at 8 ml per hour, roughly 50 hours, which is around 2 days. Because the major amount of these pains get settled within 2 days.
Will the nurse visit home?
Yeah.
You're not the hospital.
And you found this a significant pain control compared to all the other methods?
Yeah, we have tried all those. This is one of the best one. But again, I'm diminishing. This is not for everybody. You have to, because in order to be medically right also, I do it in patients who are within say 40 kilometers radius of the hospital. I don't want
not
to
the daycare, the pain wise, that is the one.
Yes.
She said, it is the one.
It is the one that works the best out of all modalities we tried.
And what's the incidence of, say, readmissions for pain?
Could I also invite
Anybody comes
because
back?
as of now, the major amount of patients we have done is for the unilateral cases.
Okay.
Bilaterals we have just started.
Sure,
I'm still
sure.
skeptical
Yeah,
of
yeah,
bilaterals
obviously.
because
Yeah.
what kind of dose to go through bilaterals are way more painful.
Yeah.
So unilaterals, it has worked pretty well. We have extended our indications now, and maybe next couple of months we'll be in a better position to answer those parameters.
No, what's the incentive for going the day surgery with? I'll tell you, the Indian scenario typically is that these elderly ladies who have never been, looked after by the family, suddenly their focus of attention, they don't want to lose that attention by going home quickly.
I share your cynicism, Hemant. I'm also the same way, but there are, as Sharon Patil was telling, the intention was wrong, but the end point is right for some instances. This daycare surgery, because if my knee is gone, I would rather recuperate second day in my home seeing Netflix and having some nice cornflakes from my wife.
Well,
he's emphasizing
no,
the
what
last
I'm
line.
saying is, that is mindset. And again, as Manoj said, we have to break traditions. You
that I understand
should not
fully.
take every Indian, like the old days, how many sutures are there, and I have to take 10 days in the hospital. The more visitors come, the more popular I am. These mindsets are slowly changing.
20 years back, our hospital stay was 1 week, and today it has come down to 2 days and 3 days.
Yeah. But what I'm saying, daycare is not for America. Again, youngsters, let them realize whatever America does. Any American is here?
Yeah.
Okay. Okay.
Yeah, we can ask his experience or
experience there. So basically, I'm sure he would agree. There are some 100% some medical legal and some socio-financial implications are there. Then the papers come out one after another.
Why don't I call Dr. Robert Coe? Right?
Please, sir, come.
Yeah. Why don't Ronald go?
No,
Yeah,
because
please
as far as-
come and share your experiences with reducing and daycare surgery if you can.
As far as my understanding is concerned, I'll take his opinion, the bundled care of a joint replacement put forth in America has changed the whole thing. So that's what the daycare surgery has come. Before that, nobody spoke about the daycare.
Yeah, Dr. Cole, would you like to?
I think Guruva is one of the entrepreneurs we have in our orthopedic fraternity. You go from Sunshine to Kims and now Blackstone. Guruva, you will get on that all corporate healthcare, especially moving on to a bottom line scenario. So you have to decrease your costs, your ALOS to make things happen.
So what do you think?
Dr. Karmanda, join us on the stage.
Really, from our standpoint, it's all about money. All about money. We're the evil West. You know, everything's driven, but we are, you know, bundled managed care was just really big a few years back.
It's microphone.
Still there, although you know the evil insurances are really against us. So even though bundled care was put as a way that okay, you're going to get increased reimbursement, that now has been really squeezed down. So it is driving outpatient. Even with Medicare or national insurance, they will not certify any inpatient to total knee replacements. Everything's certified as outpatient. So.
Yeah. Question, Manoj, for these daycare patients, do you do something different preoperatively? Means, you know, or
Very good question. Yeah. Initially, when we started with these things, we were giving a lot of preemptive analgesia, pre-gargle in the night before surgery, and diazepam in the morning or whatever. Now we are off everything, nothing to be given up. The only thing is, what is miracle that is working, contrasting to our thoughts initially, is steroids is one of the best things. The feel-good factor that you get out of these steroids is higher. B, the biggest other refrain was initially I was very scared for diabetic patients to
Doing IV or in the infiltration?
IV.
Yeah.
Initially, I was very, very scared to in diabetic patients and when you give on those steroids, but nothing works. So many times, if that's only breaking the radiation, sort of a mental block.
Yeah, we have been given steroids and that works wonderful, especially with the patient's well-being, you know, the mental side
Because
of it.
our patients are not very good on the nutrition front and the nutrition front. We talk about the Western world, but the patients are very different.
I think you know, this is basically eras. You know, I think in Indian context we should more talk about enhanced recovery, you know, rather than you know specifically take care. And I think one of the most important thing is the you know the preoperative optimization. And I think with this respect is the you know the carbohydrate loading thing. You know that's the carb loading. Now you have you know clear fluids which are carb rich. Yeah. So you know this is one thing. And the other thing is you know giving pre-gabbling, preoperative analgesia. These have been there. And you know. As far as you know, giving we have been using buprenorphine patch preoperatively. The day evening, all our patients get a buprenorphine patch, and that has made a lot of difference.
Yeah, things are changing significantly.
Again, another tradition which has been challenged and proven is nil by mouth. We keep the patient nil by mouth for 16, 14 hours without any reason. Now it is convincingly proved clear liquids like happy drink can be taken 1 hour before the surgery. 1 hour before the surgery. So. Don't let them fast for 8 hours, 6 hours.
Especially for diabetics.
Absolutely.
Right. I think in the interest of time, let's move on to interesting cases. I think the first case to be presented is by Dr. Ronald Ko. Yeah? Please.
Okay. Thanks for having me here. This is my first time in India, obviously first time to a India arthroplasty meeting, and I must say, these deformities that you guys have are just outrageous. I mean, I've never seen anything like this. So, you know, much respect. I mean, these faculty members are so talented. I have a lot of respect for them. So, I think a couple things I'll take away is, if I see any bad deformity, I'll buy them a round-trip ticket to India, search out any of the faculty members, then say, come back to me post-op. And then the other thing I think take away is, I'm probably going to go to robot course. You know, just check it out and see, because the talent, again, of these robotic surgeons is just amazing. So, okay, that being said, you may not think that my presentation is all that complex. Can I go to the next slide? Okay, so, so my first patient is basically a 70-year-old nurse, a long history of worse than knee pain, smoker, psoriasis. Typical workup, I have to do a number of things before I can get an insurance to even authorize a knee replacement. They have to typically fail 2 different types of injections: steroid, hyaluronic acid, pain medications, physical therapy, and then we can consider getting an authorization to do a knee replacement. This lady also went to another orthopedic surgeon who told her that all her issues could be controlled with a simple knee arthroscopy. So she underwent that probably 2 months before I saw her. On exam, just patelliform crepitus, limp with a valgus deformity. So this was her x-ray, and I'm not sure why anybody in the right mind would think that you could do a scope on this and improve them. But that's how she presented. So overall, not really significant bony deformity per se, but significant valgus laxity. So my thoughts are, well, let's go ahead and just kind of do a measured resection, arthroplasty. So that's what I went ahead and did. And then for the medial laxity, I've done this on a number of occasions. This is really, my practice is more of a sports practice. So take the double row suture bridge that typically was introduced in the rotator cuff repair, and I'll do that on the medial side. And so I'll do all the cuts, put the trials in, and then decide on how tight I'm gonna make it on the medial aspect. So I feel definitely more comfortable from a soft tissue standpoint doing releases, allografts, things like that to tighten if need be. So once we did that, that's just basically post-operative, and I think we corrected that valgus deformity pretty well. This lady is now out. She actually plays tennis in the same place I do, so she's about 4 years out, and she plays tennis on this knee, so she's pretty happy. Okay, so let's see. What's that?
So do you think this is your routine for any stretched out ligament on the medial side? How do you deal with the stretched out medial side?
Yes, I've had very good luck with that.
So what material suture is being used here?
Typically a polyester type suture, 2 millimeter.
So non-absorbable
tape, non-absorbable.
Yeah.
Over the top, I'll typically try to reef the soft tissues if I can. For some where there's really not much tissue immediately, I will put in allograft, typically a posterior tibial tendon allograft.
Because historically, I think plicating the stretched out structure, I mean, especially the techniques that are described, either advancing the medial collateral or plicating, double breasting, have not really shown consistently good results because they can stretch out over a period of time. Have you had any experience with stretch out?
No,
you're happy with.
Yeah, I've been pretty happy treating this basically as an internal brace.
And you're not actually transecting the ligament; you're just double breasting.
Yes.
You're collapsing on itself.
Correct. Typically tightening in about 30 degrees of flexion. The suture actually locks into the anchor.
Right.
So polyester suture, but absorbable anchors. So they're actually calcium phosphate anchors.
So would you do this for the fixed deformities?
For fixed deformities, I would think, I really kind of like to do my balancing. Like once I've done it, I'll do my balancing and just kind of get a feel for it, whether I need to do releases versus tightening on one side.
Yeah, because releasing the lateral structure would probably balance in any case.
True.
Right, that's very interesting. Thank you very much.
Sir, I have a question.
Yeah, please.
So in this kind of scenario, when we do the medial plication, along with that, if we put the knee in tibia in 2 degree, 3 degree varus, will that help? Sir, with robot, if we do it? Yeah.
You mean to say this one? Yeah, definitely.
Because that will not stretch out later on.
Definitely. Even otherwise, we normally in the manual we used to overstuff in this sort of laxity. Here by manipulating the implants preoperative, we can definitely do it. Yeah. In fact, yesterday we have done one case. Yeah, okay.
Thank you. Thank you very much. Next, I would invite Narayan. You're presenting a case? Yeah, please. Yeah, Dr. Narayan Hulse is going to present his interesting case.
Slides? How many days you brace them?
Only on that side. Slides. No, the previous one.
Or I don't know if they want you to go there.
I got it. You want to go there?
Is there? Okay, go there.
So to come to our side now, right?
So there are few, 2-3 cases are there, and I'm just going to, because of the want of time, I just run through them, and after the case, you can have comments maybe. This is a 60-year-old gentleman who had horrendous fracture, which was fixed in a remote place in this way, and ended up with a degenerative, the knee pain, severe pain. You can see the fixation as well, the original fixation. And that is the kind of the knee he had, the multiple scars, a lot of pain. So the option would have been, either the managed pain with painkillers or an arthrodesis or a knee. But if you're going to do the knee, obviously we all agree it's going to be a very difficult knee. The first thing I had to do was I write down everything, the complications and the problems and what he should expect in my own handwriting, and got his signature done. So that's what I did. What you can see here is a constraint device, semi-constraint is used, and also an offset.
What was the range of movements before you went in for surgery?
This is a very stiff knee, less than 20 degrees of flexion, around,
Okay.
10 degrees of FFD as well. It's not much, 10 to 20 degrees.
And what was the time interval from the last surgical intervention?
Around 8 years.
8 years.
Yeah,
So
8.
basically the quadriceps was all plastered to the femur.
Quadriceps was plastered. He has a flexion, no extension beyond 10 to 20 degrees of flexion only. I had to do, I'll come to that.
Yeah.
Actually, I had to do a quadriceps release, and then I ended up doing a little bit of VY-plasty to get the flexion up to the 90 degree as well. And this gentleman ended up with a quadriceps lag for more than 1 year. And after that only he got the quadriceps back. We have got his video next. So that's what he was after around 1 year time. I used a midline separate incision because it was difficult to use the same incision at that time. Anything else we could have done?
Yeah, I think, Narayan, that looks good. Only 1 or 2 learning points for the youngsters. Can you go back to the x-rays?
Yeah.
I'm sure you must be doing the trauma also, orthoplasty guys. The worst thing you can do is a half-ass fracture not treated well. This is where majority of the orthoplasty surgeons come across these pictures, because the trauma surgeon, the young trauma surgeon, doesn't know how to fix the HOFA. First learn that, how to fix the HOFA. It's not a rocket science, but a lot of people miss that. And so that is one of the things which I wanted to learn. And the second thing is, if you got a 30 degrees of extensor lag, what are you going to do? Nothing. Heavens are not going to fall. You just give a locking hinge brace, like which we give to polio people. And tell the patient that post-operatively you need to wear this brace ever. You lock him and walk straight leg, and you unlock it and sit. That's all you need to do.
Otherwise
that is the answer for extensor lag.
Otherwise they break the distal femur and
Yeah,
that's
exactly.
all.
So that, but you got to tell them pre-operatively. Again, pre-operative communication is vital in successful arthroplasty practice. Time and again. The patient will come and say, boss, you didn't tell me. So that's what you got to think of it one day before, what to tell the patient.
And essentially, if I understand correctly, surgically, is the posterior condyles that are malunited in a displaced position, and that is like a physical block to flexion.
Yeah.
You essentially will need a hinge available to you on table if you need one.
We had a hinge ready.
Yeah.
But because of the, we could manage it reasonably with the medial collateral and lateral.
But what I'm saying is a backup in this situation, because you're going to have huge, you will actually have massive posterior condylar cut here.
Yeah.
in order to develop that flexion gap.
Yeah, but if the collateral ligaments are intact, which is the case most of
No,
the
no,
time.
the knee hasn't flexed beyond 20 degrees for a long time, and the posterior condyles have sagged backwards and united in that position.
Yeah,
So they are actually acting as a flexion block for you.
I agree. We ignore the condyles and put it as augments on the posterior side. Yeah. That's
No,
what he must have
this
done.
was, I mean, basically it was malunited, and we had to basically take the normal cuts what you take. And the medial and lateral collaterals are reasonably okay. And that's where we ended up with using a normal
That X-ray
normal
actually
PS.
looks in, that X is almost in 60 degrees of flexion. So which is actually tells me that if 60 degrees possible, that's not so bad a situation.
This looks like 30, 40 degree to me, not 60. Yeah.
Okay.
And
right, thank you.
And another one. This is another 55-year-old gentleman. He had his knee problem going on since many years. And finally he had few corrective surgeries in the past, multiple scars again. And this gentleman ended up with the severe degenerative arthritis in the knee. And that is a pre-op X-ray. And the main problem was that, and we have got a CT done, and you can see the completely dislocated patella. And it's a congenital, and because a lot of them are pain-free and they manage it for many years in that position. It was difficult. Again, we ended up with this was done using my navigation, the previous system what you had. And we got the patella back in after a major release. This gentleman also developed the quadriceps leg, and it was there for a long time. And then after
medial flap, did you do double breasting?
No, only lateral release, medial normal closure.
Okay.
Medial normal
Because
closure.
many times you need to have a double breasting.
Yeah, but
Did you have a skin problem on the lateral side?
We didn't have, luckily. That could have been one of the issues because of the lateral release, yeah. And that's what we got on that day.
All right, lovely. Thank you. I think we need to move on. We have Yatindra to present one more case, and then we're already overrunning. Thank you, Narayan.
I'll just move this because the first case is hip. I'll move it to this. Okay. So the case is basically it's joint infection and fracture related infection. So it's a double problem we have. So this is a lady, obese, diabetic. She's had bilateral knee replacement. I did this. She had a lot of various deformity, so all kinds of bone grafting and everything. So she was okay. And then she broke her femur. So periprosthetic fracture in 2020. This was operated elsewhere. Then she had an infection in that, which got revised. And when she came to us in April 22, that was the condition. So fracture probably had not healed. It was in varus, and this was the implant used. And this is her X-rays. And that was the sinus for a long time. So would you consider this as periprosthetic joint infection and a fracture related infection, or just fracture related infection?
Have you been sued?
Pardon me?
Have you been sued? No.
Me?
So how does it matter? It's infection.
No. The thing is, whether are you just going to remove the plate and first deal with the fracture, or you're going to remove the whole thing?
Well, you got metal. I mean, how can you be sure that there are bacteria on the metal and not on the implant?
So that's what I'm saying. So what are you going to do now? Remove everything?
Has it reached that stage? I mean, you got to be pragmatic here, isn't it? Let's ask the panel members here.
As they say that either you have a pregnancy or no pregnancy. Like that, either you have infection or no infection. There is not little infection or a distributed infection everywhere.
I think, yeah, everything needs to come out.
Yeah,
I
everything
think
will
it's
come
quite
out.
close to the knee, means
Yeah.
Yeah. So
Okay, these are the lab parameters.
Yeah.
I mean, how bad is really the, how much is the discharge? It's really
It's
pouring.
been discharging since the time she had first surgery.
No, but is it discharging a lot? Is it only tiny discharge or small Gaussies every day?
It is tiny discharge. You can see the sinus.
Yeah,
It's
it
not,
looks
it's
like,
not
see,
greatly.
I have had some patients who are actually low-grade infections
Yeah.
and barely just a few cc's that, and it's an elderly patient. I don't know about this patient, but it's an elderly patient who is living with that. It's kind of a symbiotic relationship that they have. Because taking out the whole thing is really a massive undertaking.
So that's what I was asking, whether
you really
if
need
it's-
to
if
undertake.
it's-
That's what you need to be pragmatic here. If it is, not greatly, his patient is not becoming septic and it's not a fulminant infection. It's a low-grade infection, very minimal discharge, the implants are not loose, patient is walking around well, and otherwise practically a patient is well. You can ask the patient to just wait or maybe go for chronic antibiotic suppression.
Yeah, so that's what I was asking. So here the implant didn't look loose on the, or there was no peri-implant lucency, there was no erosions.
Yeah, if
there was
nothing of
nothing
that
like
happens,
that.
so functionally
But-
patient will be good.
Yeah, so she was walking, but obviously with the walking with a limp. But then she had infection in the fracture area. And that fracture had probably not healed. I mean, there was no way to find out whether it is really healed or no. So what do you do now? Do you just remove the plate and first deal?
From where I feel there are only three options. Either just a long-term antibiotic suppression or like a dyer, debridement, implant retention. You do a thorough debridement, implant retention, use cement beads or whatever. The third option you have is take out everything. I think these are the only three options we are trying to debate on between.
Yeah.
Please, what will you do, Manoj?
So it's quite likely that there is a sequestrum there. One of
Yes.
these fragments could well be, it looks quite sclerotic there. So on both
No,
sides, front
this
and back is
is-
cement?
This is the bone cement here.
No,
Beads.
not that. What about the...
Here. So there is a fracture line seen obliquely. You can't really make out whether the fracture is totally healed or no. Anteriorly here and laterally, anterolateral.
Maybe you get a sinogram done. You get a sinogram
And
done.
laterally.
How?
Yeah.
What part of the joint?
Here. So this is the so this is the knee joint here.
It is right there.
And there.
It's right there.
This
Yeah.
side.
Right on the top, isn't it?
Yeah.
How
So
was the
knee
movement?
joint is here.
Hitinder, how was the movement of the knee? Was it okay?
Knee
Free?
movement
lateral
was,
scar.
I mean,
Relatively
0
free?
to almost 90 degrees.
That's a lateral scar, right?
Lateral scar.
Lateral, yes.
Any aspiration?
That's where the plating was done from.
And this has been going on for over a year now, right?
2020 was the first surgery. She came to us in 2022.
So 2 years, 2 years of,
yes.
and she's
Operated twice.
And she's walking. She's but
She's walking with a walker, crutch.
She's
and
come
all
to you
those
mainly because she's worried about the limp or because the discharge is
Well,
not
discharge is continuing. She has pain, and she's not able to, walk the way she used to walk.
Yeah, I take back my words, Yatindra. As Hemant said, let us be pragmatic. I'll go down, explore the sinus, thorough debridement at that part. Whatever, if the screw, 1 or 2 screws are there, I'll take it out and come out. I don't even go and take the plate out.
So the plate is definitely stable fixation. No point.
So here, difference between.
See, because being a primarily trauma surgeon and now shifting to the arthroplasty, if there is infection, it may be, it is definitely plate this fracture-related infection, not rather one joints related. So you have to remove the plate. There is no if and but in this case because this is one of the confirmatory criteria is there. This is training for years. What if
So if you remove the plate, how do you deal with the non-union?
No. Then you have to either put
Put a
external fixator. Pardon?
Put a fixator.
Put a fixator. Debride it completely. You can put bone cement, antibiotic cement, or see what are the X-ray saying after that.
See the difference between the periprosthetic joint infection and fracture-related infection is the basic difference is that periprosthetic infection, you have to remove everything.
Yeah.
And put a spacer.
Yeah.
Whereas the fracture-related infection, you can suppress the infection.
No.
Wait, just listen to me. You can suppress the infection till the bone heals. Bone can still heal.
It is already 1 year. Recently,
No, I agree. So like you can do a debridement and you can take out the most of the tissues.
And another argument is, even if it goes to non-union, a plate with that subclinical infection can hold it. No issues.
No, you mean the fibrous union will be there.
Yeah.
Fibrous union will be there.
Yes, sir, because the other choice is very horrendous, sir. Taking the whole thing out, even taking the plate out is...
Being an orthopedic surgeon, you should not think about horrendous things or the simple things, You have to...
No, what is the best thing that is available? That is, you have to think it.
Yeah.
What is the best thing that is available for you? Ideal, take away everything, as I rightly told you.
Yeah.
No, but it's not going to happen. What I'm saying is, here, if you take the plate out, this lady is going to have both sides of the bone in your hands. What are you going to do?
No, there are other options.
What are the other options?
You can remove the part, because there might be some sequestrum also. That bone must be there. That's why it's draining since long. So you have to remove that part of the bone and deal that part with the,
So our aim is to at least first heal the bone.
Bone, yeah.
Even if there is some infection remains, you can always deal with it later on.
Yes.
Heal the bone.
Yes.
That is the first.
Yeah, that is there.
The main
So
thing.
for that you have to remove the plate.
So for
I think because biofilm will be there. Definitely.
So my options here were, one is retain the knee prosthesis, because there was hardly any infection seen on the X-ray. Though somebody says that, and I agree, that infection means infection has to be everywhere.
So
you can't
Yatin,
just
you
have
have done the
infection
case, or
nowhere.
you still?
Pardon me?
You have finished done the case?
Not yet.
Not yet. Okay. So I think on that grounds we shall hold our breath.
No. I've done the case. I've done the case.
Okay,
so I'm going to tell
tell us what you did.
I thought you were asking me here. Okay. So my
tell us
options
what
were
you did.
these two. And the options were that I retain the knee prosthesis, but remove the plate, debride it, and refix the plate with something like a cement plate or a nail. Okay. And the second option was remove all the implants, refix with the put a spacer, cement, whatever. Okay. So this was our plan. Same thing. But we also thought that suppose the bone stock was very bad, then what do I do? Whether it will ever heal? And for that we thought about resecting the whole distal femur. So we did remove everything. We removed the plate. We found lot of granulation. We found lot of.
So was it non-union or was it not non-union?
It was not fully healed, but it was not a gross non-union also. You can see from the X-ray.
So firm fibrous non-union.
Yeah. So we put nails, cemented nails that we prepare, and we put a normal, the articulating spacer. So we found a lot of granulation tissue even under the prosthesis. So we thought that it was a correct decision that we eventually.
You've gone in and put a second stage?
Pardon me?
You've done the next stage?
Yeah. We've done the next stage.
We are holding our breath.
Okay. So this is what many times we come. We can put a nail. We take the Elizarov rod and we can actually lock it also in case the fracture is in non-union. So here, after 3 months, we found that the bone was healing, and you can see that there was a lot of bone healing. CRP and ESR, they were all down by 3 months. And then we went ahead and put this hinged prosthesis, because we were really not sure about the ligaments also. Now the only problem here we were facing was that because this was in varus, whether we would be able to put the stem. So we went quite lateral, and we were able to put the stem without cutting the bone again. Otherwise, there would have been problem of again, of a malunited fracture. So,
right, wonderful. How many days since the surgery is done?
Now this is the last thing. It's about 6 months.
6 months and no infection.
No infection.
Congratulations.
Thank you.
Yeah,
The
yeah.
proof of pudding is in the eating. So on that note, I think we call it.
Yeah, Hemant, but I think this is a good message. You know, Dr. Karmanda, I think you did the right thing. So there are only two approaches. One is the suppressive antibiotic. Don't do anything.
Or remove everything.
Or remove anything.
Yeah.
Yeah.
No half
Just
measures.
go in,
No half
remove-
measures.
Yeah, just not remove the knee replacement implant when the infection is there.
Yeah, just removing the plate and leaving an implant there would not have resulted. You done well, Yatinda. Congratulations. Yeah, thank you all panelists. Wonderful, thank you.
All right, we have a little memento distribution session. May I call upon Dr. Hemant to give the memento to Dr. Vijay, please. Dr. Vijay. Yeah, Dr. Gurva, please. Dr. Narayan? Yeah, Dr. Ronald? Yeah, Dr. Manoj, just one thing. May I call upon Dr. Mahesh Kulkarni, please? All right, moving to our next session on revision TKR. May I call upon moderator Dr. Subhash and Dr. Narayan, please, on the dais.
Yeah, good afternoon everyone, and thanks Ramnik and team for inviting me. So I'm filling in for Raj Kumar here. So we have done our knees, and now it's a painful thing which we discussed since morning, that 20 to 40% are still having pain despite doing your best of the efforts. So how to evaluate them? How to find out what went wrong in them? It's definitely a problem for the patient and for the surgeon both. They have come to you for a good result. I tell everything that knee replacement or joint replacement is like a pregnancy. Everybody wants a happy ending after the surgery, and everybody wants a good result. So if there's a problem, then there's a problem for both surgeon as well for the patient. And if we talk about the causes, there are multiple causes. There can be psychological issues, physical issues, surgical issues. Let's deliberate into them. What will patient come to you? What is pain for them? There can be pain, some swelling, some discomfort, some heaviness, some stiffness, instability, paresthesias, and doesn't feel good. So it can be anything out of this. We have to keep all of them as a painful knee or a failing knee. Somewhere something is wrong, we need to find out. Now by our medical knowledge, we know how to assess the pain, what is the nature, location, radiation, does it aggravate with some activity or even the rest pain as well. Then you need to see all these things. And if you can point out the source or direction of the pain, that's important for us. Now, for the pain, there can be two different causes. It can be surgical cause, can be non-surgical cause. Now, if we talk about surgical causes, the common thing which can be the anterolateral pain on the anterolateral side of the knee at the iliotibial attachment. It's called iliotibial band syndrome, and patient can have that area pain if the implant is overhanging anterolaterally. So what I do is I keep that bony cortical area intact, so that my implant doesn't overhang anterolaterally. So I keep that area intact. I don't cut with the saw. So you can prevent the implant overhanging on the anterolateral side.
allergic pain can be there. Some people, they have these kind of lesions on the anterolateral side. We can say that it's because of the implant, but technically I discussed with a lot of my dermatologist friends, and they say it's not because of the implant. It's some kind of allergic reaction, maybe to a drug which we are using, or because the paresthesia is on that anterolateral side. It's not because of the implant per se. Now, when you see the X-rays of the patient, you need to see their alignment, patellofemoral biomechanics, joint space, whether you have elevated joint line or not, stress shielding, patellar height, or joint line alteration. So let's see one by one. So if your joint line is elevated to a certain level, you will cause a patellar baha, and that will lead to a patellar tendon impingement or the patellar clunk while patient bending the knee. That can lead to an anterior knee pain. They can be malaligned implant. Now, in standing here, people may say that these are kinematically aligned knee, but actually they were not. They are all old X-rays where they were not properly put in. And even if kinematic is gone into the valgus rather than the varus. Overall limb is not properly aligned, then patient can have the pain. Prosthesis overhang. Now, if you oversize your prosthesis, it's overhanging laterally or medially. We can accept up to 3 mm of the lateral overhang, but no medial overhang. If your prosthesis is overhanging medially, either in the tibia or femur, can lead to a pain to the patient. Posterior overhang, you can see in this axolateral view, posteriorly the implant is overhanging too much. That will lead to restricted flexion and painful flexion, so it will be a painful knee to the patient. Anterior overstuffing. If your anterior flange is too much high, will lead to impaired patellofemoral biomechanics and lead to pain to the patient, especially when they're standing up from sitting position, going upstairs, and bending the knee more than 90 degrees. Malrotation of components. Primarily the femoral component we are more important, because if it is internally rotated more than certain degrees, now with robot we are doing 1 or 2 degree internal rotation, but if it's more than that, the patella will sublux laterally and can lead to anterior knee pain. Tibial component malrotation, we tend to keep it at the medial 1/3 and the middle 1/3 junction, but if it is internally rotated, and especially with a CR knee, patient will walk with an awkward gait and will have pain while walking in normal gait as well. Now, unstable knee will also give you pain because patient will have these stretched ligaments, especially in the mid flexion or deep flexion. So you need to test the stability of the implant in full extension and varying degree of flexion. Anterior drawer sign is common with the replaced knee, but if the posterior drawer is positive, that means the knee is significantly unstable in the flexion. You can see in this video, the knee is distracting in the flexion and can have a subluxation. So these patients will have pain. You see, the posterior drawer test is positive. So that means the implant has been put loose in the flexion. Now, anterior knee pain is the commonest problem. So extensor mechanism problem can lead to a lot of anterior knee pain. It can be because of the patella is fractured, there's a lag because of some problem, flexion contracture, maltracking, or a clunk when you have not removed the superior part of the synovium. Maltracking when the implant is not been properly or the lateral release has not been done if required. Or a clunk if the proximal synovium nodule has not been removed. You just see this video carefully. The moment patient extends, the patella just drops in the notch. And there's the intra picture. There's a lot of synovial hypertrophy on the superior pole of the patella. Patella fracture patient usually tend to come late, and you see the patella is quite, two fragments are quite distracted. And it's very difficult to bring them back. So anterior knee pain, we just remove the superior synovium and just cauterize the nerve endings all around. Inferior patellar fat pad impingement is also a significant problem which can happen. So just remove this synovial fat pad distal to the lower pole of patella to avoid this kind of pain to the patient. Now, aseptic losing is a second commonest thing after the infection. So just need to see on these radiolucencies. If they're progressive, that's because of the aseptic losing. Tibial components primarily on the medial side, femoral component primarily on the posterior and the anterior side. and in doubtful cases get sequential X-rays and CT scan. So few X-rays the loosening, which can happen. Now some non-surgical diagnosis, the surgery is not at fault. There can be referred pain from the hip or from the spine. There can be reflex sympathetic dystrophy, stress fracture above or below, bursitis, tendinosis, or a crystal deposition, neurovascular problems, fibromyalgia, or there is an expectation reality mismatch. That's the commonest problem people have, because don't promise them that they will be the best of the player or they can play everything. Every patient has different requirements and every patient can reach to different level of competence. So you need to counsel them properly in the pre-op period. So just a brief of the RSD. So you need to consider other conditions which can cause the limb pain, like the diabetes, which can have the neuropathy, vascular claudication, radicular pain from the spine. Don't miss the undiagnosed hip arthritis. If there is a significant deformity of the foot and ankle, that can also lead to an unstable knee later on and have the knee pain. Good balancing and alignment is the key. Assess the patient personality, counsel them properly, and prevent any of these complications you mentioned. Thanks a lot for patient hearing.
Thank you, Subhash. That was an extensive topic and you covered well. Next talk is by Dr. Anil Arora on basic biomechanical principles of revision TKR.
Good afternoon, friends. I'll be talking very basics on restoring biomechanics in total knee arthroplasty, revision total knee arthroplasty. So to summarize and put it in a very simple way, there are 3 basic steps to restore biomechanics in revision knee. Step 1, establish stable tibial platform. Step 2, stabilize knee inflection by correct size of the femoral component, putting into correct rotation, establish the joint line. And step 3, stabilize the knee in extension and establish the joint line extension 2. It's just diagrammatic depiction of what I've just said. And the 4th step is restoring patellofemoral dynamics, which go hand in hand when you're doing the revision knee. If your biomechanics are correct, it will be correct. Now let's start with step 1, establishing stable tibial platform. And why is the first step? Because tibial surface articulates throughout the joint position, and there's a foundation on which you're going to build up your knee. And we are using tibial platform. We're not using the term joint line. That's separate. We are talking of tibial platform, the tibial bone, or your tibial tray. Now, using hand reamers, you ream the medullary canal and get the firm endosteal contact of the stem, or if you are using a sleeve, firm endosteal contact in the metaphysis. That's the step 1. Then square up the surface by removing obviously weak and dispensable bone. Don't remove the healthy bone to cover up the defects. Now you can square up the surface by any intramedullary cutting guide or from the top of the sleeve trial, whatever you are using. After having done so, we stabilize the knee inflection. Again, 3 components. Step 1, proper femoral component size, proper rotation, and restoration of joint line. Dr. Jangid pointed out the importance of joint line. If it is not restored well, there will be plethora of problems. Now, in the revision scenario, we all know the flexion gap is much larger than the extension gap, and you need to fill up the large flexion gap. Now, choose the size of the femoral component. To stabilize the flexion, the knee inflection, and it's a very deadly error to just fit the bony size, whatever is visible to you, remnant bone, and take a femoral component and put the same size on that. Now, in that case, if you're just measuring the antero-posterior dimension of the bone, left bone, and put a component, in 9 times out of 10, you'll be putting a small component. And if you put a small femoral component, then what will be the scenario? If you put a small femoral component, you use a thicker poly to stabilize the knee inflection. And if you put a thicker poly and you bring the knee in extension, you'll be cutting more distal femur and creating higher joint line, which is unacceptable. And if you don't use a thicker poly, you'll be leaving the knee a bit in unstable inflection. Now, how to choose the correct size? You can get some idea from the field component. Usually, you will need bigger component than that, or lateral radiograph of the opposite knee if it's not replaced. But the most important thing, the flexion gap, is dictated by the function of soft tissue, mainly collateral ligaments. So you lift up the knee and see what is the size of flexion gap, and then accordingly use it. What limits the size of femoral component? Number one, the mediolateral dimension of the femur, and second is compatibility of the femoral component with the tibial tray you have already decided. Besides size, the AP location of the femoral component will also affect the filling of flexion gap. What one can do is you can use offset stem to translate the femoral component posteriorly, or you can use a short cemented stem, or you can translate it posteriorly. Few companies give you this opportunity to translate it posteriorly. And whenever you do so, always use augments to provide flexion stability when the patient is getting up from sitting position. Just one small tip, if you are revising for a stiff knee, you will usually require a smaller component rather than a larger component. Step 2B, once you've chosen the size, put the femoral component in proper rotation using epicondylar axis or parallel to the tibial tray. You've already decided and put it. Now you need to restore the joint line, which is very, very important. If you don't restore the joint line, there will be plethora of problems. So make every effort to restore the joint line. Re-establish the joint line in flexion first. And what are the practical points? When the knee is flexed to about 90 degrees, the joint line should be distal to the inferior pole of patella, like here. Just one example. And I'll show you two scenarios. Scenario number one, this is a smaller femoral component, thinner augment about 5 millimeter. Thicker poly we have used. The joint, the flexion gap is stable, but the joint line is the level of lower pole of patella, vis-a-vis. Here you have a slightly bigger size of femoral component, a bit thicker augment, thinner poly, and we are distal to the lower pole of patella. Now this one is more acceptable than the previous one. And then when you re-establish joint line extension, it is said if your patella is within 1 centimeter of the superior portion of femoral component, you are quite okay with the joint line. Other bony points and the distance measured is not so correct because each femur will have different size. Now there can be meniscal remnant to guide you, or there is something called as adductor ratio. Now what is the adductor ratio? The adductor ratio came in 2014, 2014, and it is distance from the adductor tubercle to the joint line divided by the femoral width. I'll just simplify it in a minute. Now this is the joint line. This is the femoral width at the level of interapicondylar area, and the distance of joint from adductor tubercle is about 52% of the width at the level of interapicondylar area. This is one such example, and one can verify intraoperatively too. And adductor tubercle is one which can be easily palpated. It's locatable, a bony point. Similarly, in flexion, the posterior joint line is about 1/3 of the femoral width from adductor tubercle or medial epicondyle 2. And adductor ratio has been found to be correct in almost 92% of cases, 92 to 94% of cases. There are a lot of articles available in the literature now. It has been found to be very, very reliable method to restore the joint line. There is one such article published recently. Adductor tubercle ratio method was superior to the traditional method of measuring distance from the points, from the bony points at medial epicondyle, lateral epicondyle, etc. Once you have stabilized the knee in flexion, restore the joint line, stabilize the knee in extension by matching extension gap to the flexion gap. And we have already chosen the size of femoral component and the poly. Now you don't want neither recurvatum nor a flexion contracture. If there is residual flexion, you can do some distal resection of the femur. And if it is recurvatum, you have two options. One, don't use a thicker poly to fill up that gap. Number one, to use augments to distalize the femur, or you can use a sleeve to distalize the femur. Having done so, once you match both the gaps with good patellar tracking, you are through with the job and you are through with the basic steps. Thank you very much.
Thank you, sir. I would request you to please be on the podium for the panel discussion. Now I would request Dr. Manal to deliver his talk on the exposure implant removal strategies in the revision knee.
Good afternoon, everyone. Hope everyone is awake now. And thanks, Ramnik, for inviting me here for the talk. So, revision arthroplasty, two basic things which we need to understand is that 50% of the surgery is done if you take care of the exposure
and the implant extraction. So first, the 4 challenges in revision total knee arthroplasty are exposure, safe and effective component removal, bone deficit management, and fixation. So I'll be covering the first, 2, and it's very important that we should know how to approach the knee, which needs to be revised, what incision to be taken, because it's always a dilemma. We all know that the blood supply comes from the medial to the lateral, and it is recommended always to take the lateral most incision in multiple incisions, but there can be other problems as well. So when you have multiple scars, use the most lateral most. You can ignore small scars which are less than 1.5 centimeter. You can cross transfer scars at 90 degrees to the previous scars. Avoid creating skin flaps at less than 60 degrees of angle at the intersection, and avoid skin bridges less than 6 to 7 centimeters. It's very important that you create your incisions which are in the shape of a V rather than a U, because it's easier to close them. And also make sure that you elevate the scar and don't undermine, and you have to preserve the blood supply once you're doing that. So the basic exposure after your skin incision is the medial parapatellar approach, which is a standard approach in the total knee arthroplasty. But for a revision scenario, you might have to, go in and do a quadriceps snip. So this is a simple video. After I've done my medial parapatellar approach, I'm cutting the quadriceps at almost 45 degrees, almost 3 to 4 centimeters above the attachment of the patella. And you can see once it's cut, you can actually separate the adhesions and the joint is exposed easily in a revision scenario. This is the workhorse of all my revisions. Almost 90% of the revisions I can do with this approach. It's very safe and it does not lead to any quadriceps lag. It can be repaired easily, and you can do almost each and every stiff, complex knee and a revision with this approach. Other approaches are also described, like the tibial tubercle osteotomy, where you need to do osteotomy taking almost 8 to 10 centimeters of the tibial tubercle, keeping the lateral periosteal sleeve intact, and you do a trapezoid osteotomy of almost 2 centimeters, elevating the tibial tubercle and exposing the joint. So it's very helpful in cases where you have a patella baha, where actually you need to bring the patella up, or you have a stiff or a fused knee in extension, because here you can get the good flexion once that tubercle osteotomy is mobilized little superiorly. It gives you excellent exposure. Bone-to-bone healing is achieved with using screws, which are preferred as compared to the wires. It avoids extension lag, and you can achieve good flexion also, because it gives you a chance to actually increase the length of the quadriceps and the patellar tendon mechanism. The contraindications would be severe osteoporosis in a damaged patellar tendon or a previously operated tendon in such scenario. Other approaches have been described as the Viva and turn-down plasty, where you cut, with the medial parapatellar approach and go laterally into the lateral retinaculum. It is little mutilating, and you have a lot of extension lag in such approaches. There's another called the Kuhn-Adams approach, similar, where a V-shaped, retinacular release is done. These are all pretty mutilating and not recommended routinely. You can have other approaches also, like the banana peel over the proximal patellar tendon and the tibia, where you release it as a periosteal sleeve. But the usual approach would be probably a quadriceps snip in all my cases. So I'll come to the second part of my talk, which is to extract the, implant and preserve the viable host wound. So that is the most important thing which you need to be taken care of, because the more bone you damage during the removal, the more you have to reconstruct. So when we discuss revision total knee arthroplasty, implant removal is often overshadowed by the subsequent implant reconstruction, as has been shown in the previous reconstruction by Dr. Arora, that if you need to build up bone if you've removed more bone. So the battle of revision surgery is won or lost with safe, effective bone-conserving implant removal. You must have a good armamentarium with for the safe process extraction, the Moorland set of instruments, flexible osteotomes, saw blades, giggly saw wires, K-wires, metal cutting drills, and even trifines available on table. So I'll start with the safe femoral extraction technique. The giggly saw wire is used by a lot of surgeons across, but actually it's not very good because it cuts into the soft bone at the cement junction. So when you use a giggly saw wire, it usually is cutting into the cement and the bone junction and not into the cement process interface. And it's difficult where there are pegs with the femoral components, and especially sometimes with the posterior condyles are difficult to access in cases the implant has a box.
So the other the approach is to use a thin saw blade, which I commonly use in extracting the femoral component, where the saw blade works in between the cement process junction and cement implant interface, and you can even access the posterior femoral condyles. And you can the surgeon and the assistant can work on both sides to remove the implant. You can have flexible osteotomes, which are very good in accessing the posterior femoral condyles. So you can see the same patient, I'm using all these things. And there's another technique which is called the double extraction technique, where the surgeon and the assistant, they put in the osteotomes on each same place on the opposite sides of the implant, and together they hammer the osteotomes at the cement implant junction. And because of that resonance effect, the implant is said to loosen out and come out quickly. That's called double extraction technique of the femoral component removal. And you can use the specific instruments available from the market, where you do a safe process extraction without any loss of bone. Make sure that if you have to apply too much of the force, that means your bone is still holding onto the prosthesis and it will come out with it. So be sure that it's not so. The tibial extraction, you can similarly use flexible saw blades, disrupt the implant cement interface, or you can use a technique called the stacked osteotome technique, where broad osteotomes are stacked on the undersurface between the tibia and the implant, and then you keep adding osteotomes, 3 or 4 osteotomes, and it will actually build up and pull the tibial component up and out. So that's very easy technique, and then you can use a punch just to build the bring the tibial component out. So you can see here, this is the instrument for the tibia, where the tibial component has been extracted, and the whole of the cement is still intact there. Cement stem extraction can be a difficult problem. You can just pull in the stem out with the shear forces, and you can have a centralizing drill, and then you use a reaming kind of a cannulated reamer kind of a thing, and then pull in the plug completely out. The problem comes with the cementless porous coated stems, where you actually have to disrupt the porous ingrowth using flexible K-wires and flexible osteotomes, and it can be pulled out completely once you've disrupted the implant junction. Sleeve removal can also be a big problem. If you are able to disrupt the modular components and bring in the stem with the femoral component, then make an anterior cortical window where you can assess the sleeve and disrupt it using flexible osteotomes and K-wires and bring the components out. Cone removal is another problem which can be a challenge in revision surgeries, where you can see I have made an anteromedial window on the proximal tibia, and you can punch out your modular components out, then get the tibial tray out, and the sleeve which has been fixed with the cement to the bone needs to be taken out in piecemeal, because it's very difficult to take it out as one piece. A lot of bone has ingrown. So to take home message is that when you have a revision, you must be having all the components available. You must be having lots and lots of bone metal cutting instruments available. Tefines also might be required if you have stems inside, K-wires. So the basic thing is follow the basic principles, be patient on table, keep everything ready, and make sure you do not lose more bone while revising. Thank you.
Thank you, Mrinal. That was a nicely covered talk. Next, I will invite Dr. Mahesh Kulkarni to deliver his talk on implant selection and bone defect management.
Thank you very much, Ramnik. I'm probably going to stick to only bone defect management, because I think the time is restricted. Can we have the talk, please? Okay, so the management of bone defect obviously depends upon the severity of the defect as well as the location of the defect. We have variety of options. You can use cement, you can use an augment, you could use bone graft, either structural bone graft or cones or sleeves, and ultimately leading to tumor prosthesis. The classification that is considered commonly is the Anderson Orthopedic Research Institute classification. Type 1 in these cases is a minor bone defect, and the stability of a revision component is not compromised. And there are posterior condylar areas is also well preserved, so you can easily reconstruct this without any problem. This is rare in a revision knee replacement scenario. When you've taken your implants out, you are probably less likely to be left with such a minor defect. If it is less than 5 millimeter, you can use cement or mossealized cancellous bone graft, depending on whether it's contained or uncontained, and always consider using a stem. Variety of studies have said that if you don't have a tibial epiphysis or a platform and you have a big defect, then you should supplement it with a stem. The stem could be either a non-cemented stem or a cemented stem. A non-cemented stem unfortunately needs to be very snug in the diaphyseal area, and you might end up having mid-shin pain, which might be self-limiting or sometimes very painful, could need revision as well. However, a non-cement stem is better if you have to revise it further. If there is further infection, it is probably slightly easier to remove as compared to a cemented stem. Based on literature, both cemented as well as hybrid stem fixation, where you actually cement the metaphyseal area and don't cement the distal part of the stem, which is a technique I prefer because there is ease of insertion. You don't have to address the diaphyseal cement if further revision is required. And with this technique, end of stem pain is pretty rare and self-limiting. A type 2A defect is there is metaphyseal bone damage, cancellous bone loss is there, one femoral condyle or a tibial plateau might be damaged as well. In a smaller defect, you could either, in an elderly patient, less demanding patient, you could consider a stem along with bone graft and screw fixation, or you can consider using augments depending on the size of the defect that you are left with. Type 2B and 3, I'm grouping them together. In type 2B, there is metaphyseal bone damage, cancellous bone loss, and both tibial plateaus or both femoral condyles might be completely lost. And in type 3, you will have significant loss of metaphyseal bone as well as maybe the ligaments are gone as well, where you need to start thinking about a hinge or a tumor prosthesis. What are the options for 2B and 3? You can either consider impaction grafting, structural allograft, or replacement with either a metaphyseal cone or a metaphyseal sleeve, which will allow you to have a stable platform and rebuild the damaged bone. Impaction grafting is a very exacting technique. You need to have access to fresh, frozen bone, which unfortunately is not available in many of the centers. I don't think you will get good results with irradiated bone, so you need to have either your own bone bank or have access to the bone bank, which gives you fresh frozen bone graft. You need to use meshes if there is a peripheral defect. Otherwise, you can impact the bone graft in a contained defect and go with a stem and a standard fixation. Structural allograft again is a problem with accessibility. We don't have access to structural allograft. Unfortunately, these in the long term will have problems with resorption, fractures, infection, and non-union. So we're left with two options, either porous titanium cones, the T-Mars cone, or now the 3D printed variety options are available for us. You can either use a broach or a burr or a combination to prepare them. You need to unitize that cone with this implant with cement, which goes within the cavity of the cone itself. It gives you need to assure adequate stability on day one. So you need to have a stem which has good purchase in the diaphyseal bone, which will allow you osseointegration or a chance of osseointegrating the cone itself. The results have been good, with long-term results of failure only in 1.1%. Again, you can see survivorship is nearly 96% of these constructs. What about metaphyseal sleeves? These are different to the cone in the form that they are press fits, which will allow you to get axial and rotational stability, and the stem itself has a more taper junction which fixes to the sleeve. So the weight bearing is transferred from the implant through the sleeve into the bone, which will load the bone and preserve the bone stock in these patients. Here is an example of a metaphyseal sleeve which allows you to get away with fixation in deficient cancellous bones. What you need to understand is also understand this zonal fixation concept, which was popularized by Ridian Morgan-Jones and Faris Haddad. It gives you a framework for preoperative planning and understanding where you can secure fixation. So you have considered three zones as you see in the previous slide: the joint surface or the epiphysis. The second zone is the metaphysis on the either end and the diaphysis on either end. So the basic concept is you need to achieve fixation in 2 zones out of 3 to have longevity of your revision implants. In zonal fixation for the epiphysis, If the epiphysis is the area, surface area on the femur and the tibia, you need to free that surface of the cement debris, avascular bone, fibrous membranes, and then consider fixation in one more zone. So you need to have a stem which either achieves fixation in the diaphysis, or you need to have either fixation in metaphysis with a cone or a sleeve. If you rely on metaphyseal fixation, again you are closer to the point of articulation. That could be your second zone of fixation. By using a metaphyseal support like a sleeve or a cone, you don't need to have a stem which is tightly fixed into the diaphysis, and you could get away without using an offset in your system if it doesn't offer you so. And finally, the diaphysis, we've talked about cemented stems, either using a cement, so the metaphyseal fixation could be either a direct fixation, which is using the metaphyseal sleeve, because that is a weight-bearing construct. Or you can have an indirect fixation, which could be like a trabecular metal cone, which will act as a filler and give you a stable platform depending on what kind of bone is available to you. And finally, in diaphysis, you can either use a cemented or an uncemented stem. We've talked about merits and demerits of each. So the concept of zonal fixation gives you a working methodology. You need to have a combined approach for fixation. At least two zones need to be engaged to give you a stable construct. You need to understand which are available for fixation, what implant should we use, what is affordable for your patient, and what is accessible to you. So in conclusion, in type 1, in less than 5 millimeter defects, you can go for a cement or a graft. In between, you can go with a metal augment or metaphyseal sleeves or cones. And 2B and 3, definitely either impaction grafting if you have access, or porous cone sleeves, or revision, the tumor implants. Thank you.
Thanks, Dr. Kulkarni. Please be on the podium for the panel discussion. Now, I request Dr. Rajiv to deliver his talk on the level up, that is a hinge or the condylar replacement processes.
Thank you, Subhash. Thank you, Ramnik, once again. I'll be speaking on role of hinges and total condylar replacement in revision total knee arthroplasty. Now, total knee arthroplasty is slightly different than the primary because it has a greater bone loss, it has a greater ligamentous instability, and that's how the constraint also needs to be increased, whether the condylar constrained rotating hinge or a tumor prosthesis, depending upon the situation, and that's what we will discuss in next few slides. These are the various implants which are available from the non-constrained to the most constrained implants. Semi-constrained when you have a ligamentous insufficiency, hinged when you have a significant disruption of the ligaments, and the tumoral prosthesis when you have a bone loss, the large amount of the bone loss. The two things are important. First, stable fixation to fill up the defect, which Mahesh has covered very well, and second is the constraint to control the instability within the joint. Now, three things are important. One, use the constraint components infrequently, know when to use them. Second, always go to the surgery with the constraint implants ready in your theatre, and never go to the surgery planning to use a constraint implant whatever condition may be. So, constraint implants need to be ready in such a situation, this example, where you see that there is a significant flexion instability. That's how the careful removal of the implants, and then you have a uneven asymmetric flexion and extension gaps. Now, this patient was treated by the increasing posterior release, increasing distal femoral cut, external rotation of the femoral component, and increasing the size of the tibial insert. And that's how the PS150, the posterior stabilized knee was with the extension stem was used, and minimally constrained implant was used. So there was no need of in this kind of a situation necessarily to use a constrained implant, because not in all unstable joints. So that's a very good example of that. And then we see adding the constraint means that you will also have to augment the prosthesis fixation. So with that, you have the cones, sleeves, and extension stems, which have been covered already. So only two important points, stability and fixation in such a situation. the Radian Morgan Jones zonal fixation